प्रतीपितचर सुचिराशुभायु वेदस्य दीपाविहतः पुरदोतरा येन प्रभामय विहस्य विदध्य दिक्षु ज्योत्स्नामृजाति शमने प्रभवे मदाति व्यादिव्यकान्त हृदयाय देयं द्वितं भुविकलापि च न किलैषः देयं द्वितं भुविकलापि च न किलैषः देयं द्वितं भुविकलापि च न किलैषः
Primary prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you. So good morning to everybody. On behalf of IMA Puducherry, I take this opportunity to thank the JIPMAR as well as the Department of Neurology, Dr. Sunil Narayanan sir, HOD, and the Department of Medicine for organizing this stroke update exclusively for our IMMs. I said because few years back, Dr. Sunil Narayanan sir has invited me to be one among the panelists for stroke update. At that point of time, he was actually insisting our IMA members, especially the general practitioners, to know about the stroke update, especially because most of us do not know, right? When we see, and especially from the diagnosis point of view, and how to refer, and how quickly we have to refer, and then where to refer. So all these things he has highlighted on that day, sir, which thank you very much, sir. So today, I thank on behalf of IMA Puducherry, I must thank the director of JIPMA, Professor Dr. Negi, sir. Due to personal commitments, he could not come here. And then our superintendent, sir, Dr. Dorai Raj, sir, whom I know for many years. And then, of course, Dr. Head of the department here. As, in fact, during our COVID times, I know very, very well, right, how multi-departments, I would say, not a single department during the COVID times. I have to thank many faculties here at JIPMAR, especially Dr. Vivekanandan sir, Dr. Anucharian in the critical care unit. They have responded every time, whenever we call for our doctors or for our doctors' relatives, they have helped like anything. Today, I know most of the faculties here at JIPMAR. I'm really grateful to know each and everyone at JIPMAR, though I am not from JIPMAR. So as a secretary, past president, and the present secretary, in fact, medical superintendent also was saying, you were the president before, and now the secretary. Yes, of course. But still, people love me to be the secretary, to continue at least with the IMA activities. Thank you very much for one and all. And all this credit goes to Dr. Sunil Narayanan, sir, especially for arranging this stroke update. It's an academic feast. I know very well because I was there on that day. The whole day program was conducted by Sunil Narayanan, sir. So today also, our IMA members can highly benefit from the stroke update and hope everyone will go well with knowledge of stroke update, how to handle those patients and how to diagnose also. Thank you very much. Now I request our medical, Dr. Sunil Narayan sir to give his introductory remarks.
Good morning to you all. First, thank you very much for joining us on this very important meeting, which is actually a mission for all of us who are working in this very important area of neurological care, that is stroke services all over the country, to disseminate what's happening not only in the scientific and medical world of stroke treatment, but also on the way the government is gearing up to make sure that the best of the care reaches the needy people in the community. So with this idea, the Director General of Health Services is actually planning out programs. A lot of programs are in the pipeline. Many changes are going to happen. Fortunately, we are also part of these processes into the some of the planning of how these programs should be developed, and the writing up of the guidelines for acute stroke care services, and how it is to be organized in the country. So by the next this year's World Stroke Day, the program will come into. We will be actually releasing these guidelines, but right now very active discussions are happening, and this is one of the important things. Is we don't have to wait for these guidelines to come out as a book or anything. Already there are existing guidelines. Only there are some very small incremental changes coming up to better deliver the care and services. So today we are going to give some overview of what's happening, what's going to happen, and what is the role of all of you, who are the most important elements in the delivery of the care at the grassroots level. So today's program will be covering about these organizational elements of stroke care, and also how acute ischemic stroke therapy and hemorrhagic stroke therapy is planned to be delivered, and then also very important aspects of the secondary prevention of stroke, and finally, not finally, and also on the importance of pre-hospital stroke care, in which some of you may be practicing in the community, but may or may not be attached to a existing hospital with all services. What is your important roles in organizing and delivering this care? So the pre-hospital care is also very important. So that's going to be the second talk, and the third talk is the secondary prevention of stroke, which is is as important as the acute care, or in fact even more important. Then we'll have a panel discussion. In this panel discussion, there will be talks on primary stroke care, and also on various government schemes available in helping the needy patients and their caretakers in stroke acute care, prevention, as well as in rehabilitation. And there will be also various other elements of the service, including rehabilitation, to be covered. And you can also ask questions. So with this brief words, we would now request our director could not be present in person, but he's giving his introductory remarks to us through an online addressing of this audience. Dr. Veer Singh Negi has recently joined as our director, a very eminent physician. He has been with us for a very long time, and he's back to JIPMER as its director. He's going to address us now. Thank you.
So before that, let me introduce our guest of honor, Medical Superintendent, Dr. Dorairaj sir, Dr. Lal Kudi Narayanan Dorairaj sir. He has finished his MS, DNP and MCH Urology. He is a professor, senior scale officer in charge, purchase section, transport section, and multidisciplinary robotic assisted minimal access surgery unit at JIPMA. The areas of treatment: laparoscopic surgery for urological diseases, percutaneous nephrolithotomy, and ureteroscopic lithotripsy for stone diseases, kidney transplantation, live as well as deceased donor, and vascular access surgery for dialysis surgery for urological cancers, including radical nephrectomy, cystectomy, radical prostatectomy. He is an expert in many urological surgeries, including reconstructive urological surgeries such as urethroplasty, percutaneous and ureteroscopic lithotripsy for urinary tract stone disease, laparoscopic urological surgery, kidney transplant, everything. So he has joined JIPMER in 1999 as Associate Professor for Urology and subsequently became Professor of Urology in 2003. In 2013, he became the head of the department. He has established percutaneous nephrotomy, and again, he played a leadership role in establishing kidney transplantation services in the department and performed the first ever deceased donor kidney harvest for transplantation in Pondicherry. Dr. Dorairaj sir had his undergraduate education in medicine at the premier All India Institute of Medical Sciences, New Delhi, AIIMS. He subsequently did his post-graduation surgery and super specialization surgery in urology, MCH, at AIIMS. At AIIMS, where he received training in laparoscopic under Dr. Ashok Hemal, a pioneer in robotic surgery in the world and a leader in laparoscopic urology in this country. He was awarded the Chakrabarti Fellowship for the year 2009 by the Indian American Urological Association. He has served as Assistant Professor of Urology at the Nizam Institute of Medical Sciences, Hyderabad, and as Assistant Professor of Urology at AIIMS before joining JIPMER as a faculty member. He has received numerous acclaimed awards, including Chakrabarti Fellowship for the year 2009 by the Indian American Urological Association, as well as several awards for his scientific contribution at various regional and national conferences. Publications, he wrote 9 book chapters and serves as a referee for many leading urological journals, including editorial board appointments for 2 journals, including the Indian Journal of Urology. He has been invited as a faculty for many CMEs and workshops, secretary of the Tamil Nadu and Pondicherry Association of Urologists for a 2-year period, 2014 to 16. He served as a past president of JIPMER Scientific Society, treasurer and Pondicherry Renal Sciences Society, and treasurer of the Pondicherry Surgeons of Association. He has been appointed by the MCA to inspect various medical qualifications, considering recognition for the new MCH PG courses. He has been as an appraiser for DNP courses, and then he involved in the teaching and training of students of MS General Surgery and MCH Urology. He has guided many postgraduate students in the dissertation work. Professor S. Kumar and Dorairaj sir has prepared the draft of the revised curriculum of the MCH Urology course of JIPMER Puducherry that has now been implemented in JIPMER. He has coordinated several education programs and CMS. With this, may I request our Medical Superintendent Dorairaj sir to brief.
Good morning, everybody, and thank you, Dr. Srinivasan sir, for a rather long introduction. Respected President of the IMA, I think he's on the way, and he is also a urologist, Dr. Sudhakar. Am I right, sir? He's on the way. Yeah. Respected Secretary, IMA, Dr. Srinivasan sir, Head of Department of Neurology, JIPMER, Dr. Sunil Narayan sir, senior practicing urologists, colleagues, academic practicing doctors in the community, academic doctors, postgraduate students, ladies and gentlemen. I'm indeed happy to be present here on the in this IMA program. And it is particularly satisfying for me because as a personal wish, I used to believe that IMA should collaborate with academic institutions and conduct these programs, preferably in institutions. We have had long time ago the Pondicherry Urology Group meeting in the Indira Gandhi Government General Hospital, Pondicherry, and in Jipmer and in Mahatma Gandhi Medical College by rotation. Of course, I'm not saying that it still works. And I hope that going forward, besides having it in hotels, these programs will also be held in academic institutions like the Indira Gandhi Government General Hospital and PGI, the Indira Gandhi Medical College, the various other medical colleges like Mahatma Gandhi Medical College, Pondicherry Institute of Medical Science, and there are several of because that would give a stimulus to more people participating. Coming back to the topic, the government of India has given great importance to stroke, its prevention and various aspects of management. Under the National Program of Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke. And they issued guidelines in 2019 by the DGHS on various aspects again, including primordial prevention, primary prevention, secondary prevention, rehabilitation. And these guidelines, as Professor Narayan mentioned, are in the process of being revised, and very soon we would be having the fresh guidelines. Professor Narayan has been a member of the guidelines committee that made the guidelines in 2019, and he continues to remain a member in the committee that is revising it. So what we are going to hear from today is something really fresh. We all know that stroke is an important and disabling condition, and but when I was an undergraduate student in medicine, it used to be felt that very little can be done to avoid the disability. But now a lot of advancements have taken place in terms of early intervention, in terms of unclogging the interventional radiology methods, and various other surgical methods that can reduce the disability, maybe completely avoid disability altogether, and prevent future occurrence of stroke. So I'm sure we'll be hearing about a lot more of it. And from the government side, from a public health angle, what is the role of practitioners in this? There is a very important role in prevention of the modifiable risk factors, such as lifestyle modification, where good control of diabetes and other hypertension and other risk factors, as well as early detection and action. So there is a lot of things that can be done by a practitioner at the community level, which can play a substantial role in reducing the morbidity, early referral, identifying the cases which actually need referral so that the referral centers are not overburdened with a lot of patients, and developing sophisticated centers for more advanced intervention. I'm sure we'll be listening to all these as we go along. And government is also planning in the same way of developing a hub and spoke model of developing centers for referral, which will cater to the community rather than sending everybody to institutes of higher learning such as Indira Gandhi Medical College or Jipmer or AIMS. So I wish this program all success, and I'm sure it will be very fruitful for all the participants here. Thank you very much.
Now we'll have the recorded message of our director, Chipmer, Dr. Negisa. Good morning.
It's on the window website.
Good morning, everybody. I am glad to be invited to this important meeting of the Puducherry chapter of IMA, which has been organized in collaboration with the Department of Neurology, JIPMER, Puducherry. Stroke is the most important cause of disability in the elderly and second commonest cause among all adults. With an increasingly better control of communicable diseases and with the increasing longevity of life in our country, NCDs such as ischemic heart disease, stroke and cancers have emerged as the leading cause of death, and stroke is now the second commonest cause among the NCDs. Stroke care has recently advanced at a greater pace with several time specific interventions, and a CME in this subject is always beneficial to all who provide care to adult patients. The contribution of community and peripheral doctors is very crucial in proper management of this devastating condition, as well as in the further management of the patients in rehabilitation and prevention of further strokes. The doctors in community also serve to provide health education to healthcare workers and public. Hence, centers like JIPMER and other tertiary care institutions have to work in constant collaboration and cooperation with community doctors, while the periphery doctors have to provide timely and urgent referrals for advanced care centers. They also have to take care of the rehabilitation and long term care of these patients. JIPMER provides acute thrombolysis, mechanical thrombectomy and state of the art preventive care and rehabilitation for strokes. We are also planning to start telemedicine based supervisory support and medical care in pre-hospital evaluation of the patients. I wish the IMA and Department of Neurology all the success in this venture and congratulate them in organizing this important meeting. Thank you.
So let us move on to our main topics. So let me invite Dr. Sunil Narayanan sir for today's talk on update on stroke care, role of community doctor and the hub and spoke stroke care model. Dr. Sunil Narayanan sir is the chairman. He is the chairman stroke subsection Indian Academy of Neurology. He is a member of Indian Academy of Neurology, and then he is the Commonwealth Scholar 2007 to 9 Neuro Rehabilitation, and he is the JIPMER Research Day Faculty Oration Awardee 2022, JIPMER Scientific Society Internal Oration Awardee 2019, the Indian Academy of Neurology Neuro Rehabilitation Initiative of the Year Awardee 2024, and ex-president Tamil Nadu Association of Neurologists, and he is the ex-president JIPMER Scientific Society. So today is going to talk on update on acute stroke care, what, when, and where. Please, sir.
Thank you. Since we are running a little late, I think I should take the plunge and directly get into the important topic. I already given the background in which we decided to very quickly get into the stream of all community doctors and try to involve your active awareness and your active participation in these significant changes that the government is planning, and we are all happy to be small elements in this chain of activities coming up. So I wouldn't be going in very great depth into how exactly you select the patients for different therapies and what are the actual elements of delivering these recent cares, but it's more about the strategic changes and a little bit into the specifics of the treatment as well. How do you change this? Okay. So already our respected medical superintendent and director has already told us why stroke is become such a very important medical illness. We all know that with the general improvement in the healthcare all over the world, especially with its high impact in developing countries, low middle income countries like ours, the lifespan of human beings have increased. People have started living longer, and along with that, in addition to the previously existing communicable diseases, which fortunately we are being able to have more control, the non-communicable diseases have started emerging as very, very important health problem. And when you look at it, the previously people thought that cardiovascular disease is a disease of more of the affluent people. But now we know that actually the burden is more in the lower income people. In the economically deprived, socially deprived people actually have more proportions having strokes than the affluent people. So that is really worrying. They already had these problems of communicable diseases, malnutrition, etc. Now we are understanding that even the non-communicable diseases and their impact is also actually more on the socially and economically deprived people. So countries like ours have a very large proportion of the patients in this people in this strata. Our stroke burden is also very high. The other reason why we are more excited and more worried about imparting better care services in stroke is because certain very important therapeutic avenues have become available in the last couple of decades. And with the NH stroke trial in 1995, there is a very effective treatment for stroke, just like we treat acute myocardial infarction and acute coronary syndrome. We can now safely give thrombolytic drugs intravenously within a window of time, and then provide care. And also we have a more, even more powerful treatment like mechanical thrombectomy, just like the cardiologists used to remove the clots. We can now remove the clots in the cerebral blood vessels as well. And the number needed to treat is as low as 2.5, one of the very most impactful treatment procedures in acute ischemic stroke. And stroke units are also important. If you geographically keep patients in a particular area and there is a multidisciplinary care, the outcome has been found to be far more important, not only in the developing world, but also in the developing world, and not only in the central hub, like bigger hospital, but also in the smaller hospitals and primary health centers. So this focused care significantly, looking at small things like care of fever and nutrition and swallowing, etc., makes a huge change in the outcome of the stroke. This is why stroke has become very important. I wouldn't go into these things. We have already told about this. And you know, India is in that sandal color, brown colored area. So ours, though we are a little less in the stroke incidents compared to Russia, China, and some of the African countries, compared to the rest of the world, we still have this prevalence of stroke much more than any other place in the world. These are some of the studies which we did long back in the periphery. That time I was an assistant professor. We used to go around with the students, and through some ICMR project, we did these studies and found out these kind of patients, completely neglected young fellows with a rheumatic heart disease and cardioembolism. So we found out that there is around a prevalence of around 4.66% of strokes, which is a very significant percent. The national prevalence is 2%, but that's an underestimation actually. If you go to the periphery and see patients on a home-to-home survey, you can really see much more higher prevalence. So So the levels of stroke care is something which we are now all talking about, and where these levels of stroke care are delivered. We have acute stroke care, post-stroke care, then secondary prevention of stroke, primary prevention. But I won't be touching upon all these things. I would be speaking mainly on the acute stroke care and a little bit of the stable phase stroke care, that we can call as post-stroke care. In the treatment of stroke in the acute phase, time is brain, and this concept was 1993. Camilo brought it, and then that is when that stimulated the discovery of the thrombolytic drug and its the time awareness, the window awareness, and then there was a lot of activation all over the world by the World Stroke Organization to spread this message that acute stroke treatment is as important as acute coronary syndrome or myocardial infarction in saving lives and reducing disabilities. So how this is important and an impactful changes made in the society as to how they look at stroke and how we care for stroke patients. It all starts with education. Education of the public at large, education of the community doctors, education of the health workers, and even starting right from school children, that there is stroke is a treatable disease, and for it, the treatment has to be for its effectiveness. Treatment has to be delivered in a very short early window, and for that, recognition of stroke is very, very important. So, with this idea, the early recognition importance comes very first, because without recognition, you can't think of imparting specific care for that specific disease. So the treatment education can start even in schools. Actually, it's a school health program which gives nutrition, looks at infections, etc. Teaching students about their own, not only about the anatomy and physiology of the body, but also about some of the very common, very important preventable diseases. That information, that knowledge should be imparted to the school children as early as in their primary and secondary school education. So a lay person should also be taught to recognize it. And there are various studies which have found that by imparting the knowledge to communities, the time at which in a community the patients seek help for stroke and the acute stroke care delivery has been given has changed a lot. So with this, WHO came up with these slogans like fast, where there is, and then be fast, the balance, eyes, face drooping, arms pitched. And if these are involved, if any of these are involved, we should think it is a stroke, because no harm is done even if you overtreat. There are also studies, stroke mimics being treated with thrombolysis and with no significant harm being done at all. So the time is the essence. So we had to call ambulance, or we had to make other arrangement, take the patient to the appropriate stroke care delivery center. So this is the Be Fast mnemonic, and calling in India, it's 999 or 102, 108. We have different states following different ambulance numbers. But even if you call 999, they are supposed to connect us, and there in the pre-hospital care talk, there will be more knowledge will be imparted by Dr. Manu on this thing. So these are the warning signs of stroke. So why I'm spending a little bit of time is the recognition of stroke in a family member of yours, or in a neighbor, or in one of your close relative, or anybody in a person at your workplace is very important. And then you have to take lead in making sure that the patient reach an appropriate care delivery center. So this is the algorithm for acute management of ischemic stroke. It's a busy slide. You can very well see that all the information that we need is, when was the person last last known to be well? And then what is at the moment? The NIH stroke scale, of course, you need a doctor or a supervised neurologist advice, either through telemedicine, WhatsApp. There are all sort of very innovative, remote medical diagnosis and care is now being provided. That's all in the pipeline. And we also have to know what is the pre-stroke MRS. Suppose somebody had already had a stroke, or somebody had already had a Guillain-Barré paralysis or a polio paralysis, or due to some other fracture, some disability. It's important to have some awareness from the history so that there is no overdiagnosis or not. And we also get to know whether it's a new problem or it's there are various stroke mimics, and there are also stroke chameleons. So all these things we have to be aware of. So it's important stroke morbidity also. And then depending upon this time windows, we'll go a little more into this detail later on, and we'll come back to this slide again. So now this is perhaps the future. Right now, patient has to reach a center with a CT brain scan facility. And then CT scan of the brain is a must. There is no acute stroke treatment without a CT scan of the brain. And how much time it will take for a patient with a stroke to reach a center with a CT scan depends where he is living, isn't it? It's more than money. If he's in some remote part of the world, in some hilly area or in some other jungle area, to reach the a center with a stroke facility can itself take away a lot of time. So can a CT scan go to the patients? Then again, the problem, how can the van reach? If the patient cannot reach, how can such a big van reach? So that's also a big problem. But these are some of the things which the West and other developed parts of the world has developed. So it will take some time for us to have such networks, but it's important to know these are possible. What is more important is to have different strata of stroke care services spread out throughout the community. We have, because of this reason, the World Stroke Organization has developed these 3 different strata of stroke care center. And World Stroke Organization always aims at providing care even the least developed parts of the world and the economically most deprived areas of the world. So we have minimal stroke care facility, which can be even in a remote village area, which can be in a hilly area, which can be in any rural area, and any small nursing home or a primary health center, or even some of the suburban, some other sub-centers of this primary health center can have this basic care. And the aim of the government is to have such basic facility which will cater not only to the care of acute ischemic stroke, but also for acute coronary syndrome or acute renal failure, and also acute pulmonary failure due to exacerbation of COPD or whatever. Such acute problems can be given first aid, life-saving support, and then basic investigations like ECG, and then to see whether it's a acute cardiac problem, etc. And then transported to a place where the specific therapies like thrombolysis can be given. So the first one is minimal stroke care facility. In the essential stroke care center, there will be a CT scan. So it can be, as I told you already, it can be a district hospital, or it can be a private hospital with a CT scan facility. In a country like India, the reality is that without public-private partnership, no realistic, good universal healthcare can be provided. So even though we work in government hospital, there is no point in only glorifying government services because it is subsidized significantly to public. The delivery of the care at the acute phase with the support of other kind of government support schemes, which we'll be talking later, is also important. And it's happening. It has already started happening in our country in a rather very effective way, I should say, considering all various constraints that we are having. And then in advanced stroke care center, the thrombolysis beyond the conventional windows over 4.5 hours. That 4.5 hours is the conventional window, which most of you will be aware of as far as stroke is concerned. Beyond 4.5 hours also, you can do thrombolysis. And there are also more effective treatments like thrombectomy, which has a windows as long as 24 hours. And sometimes people are also thinking whether tissue-based, image-based, functionality-based thrombolysis and thrombectomy can be extended even beyond that time, actually. So all these can be done in only advanced stroke care center because this involves advanced imaging. And it also involves preparation for eventualities, like if there is a hemorrhagic complication, if there is a brain edema complication, a neurosurgeon, neurosurgical support has to be available. So it's important that care is done in advanced stroke care center. So all these minimal stroke care center should be connected to the essential stroke care center. They should have a list of essential stroke care center. Essential stroke care center should have a list of advanced stroke care center. But if minimal stroke care center itself understands that this is a major problem and it needs not only thrombolysis, but will need further advanced care like thrombectomy or surgical treatment, etc., then they can directly go to the advanced stroke care center also. So, so we have this hub and spoke model, and the advanced stroke care center, and sometimes the essential stroke care center can and should be and will be connected with the minimal stroke care center or minimal NCD care center to be more realistic in countries like ours. And they should have a free exchange of communication through digital media, which is now fortunately very well developed in our country. And information can pass both ways. You can give telemedical advices. You can actually, after the treatment, patients can be sent back to the referring center, etc. So in a minimal stroke and coronary care center in the periphery, it can be removed. It is usually very much in the rural or other isolated geographical areas. They should take care of the airway. It's not giving the pointer, is not there. So the airway, breathing, and blood pressure, circulation, and perhaps an ECG, these things should be available there. And you have to provide, even in a stroke, there should be a pulse oximetry available in all these centers to make sure that there is an oxygen saturation maintenance, whether it's acute coronary syndrome or even a stroke. More than 90% of oxygen, if that is not maintained, some oxygen supplementation should be there, and preferably it should be continued. Not preferably, it should be continued until it reaches the essential stroke center or the higher centers. And the only thing which we need is a sugar estimation as far as biochemistry is concerned. And if there is very low sugar or very high sugar, treatment should be initiated there itself. And of course, airway, and if the patient is in shock, giving fluids, etc. So basic life support cares should be imparted in the minimal stroke and coronary care center. This can be expanded to the, as I told you, acute NCD care facility. So these centers, there should be personnel, who it can be anybody, to use a pre-hospital stroke assessment tool if possible. And the time of onset of the stroke symptoms is very, very, very important. So that information can be very most of the time got only with someone who is staying with the patient, and he may not be able to go all the way to the other centers, the advanced centers or the other hubs. So this information should be noted then and there, the time of onset of the stroke symptoms. So if you think it's a possible stroke and it needs care, then patient should be transported to the closest hospital capable of providing essential stroke care, including a CT scan, and definitely a CT scan. There should be protocols already established. We shouldn't be thinking out of the box or to find out what we should do. There should be established norms, plans to immediately transport the patient to the closest hospital capable of providing such a care. And there will be protocol for emergency inter-hospital transfers, and identify such centers with the correct address and urgent notification of the phone number. They should be informed that such a patient is coming. So we must maintain a list of geographically closest essential stroke care center capable of providing more advanced stroke care center. So this is what you must all have information with. When a patient comes to you with a suspected stroke, either you are attached to a hospital which can take a CT scan and get that information, or you know where is the nearest hospital. Of course, you all know where you are practicing, but the telephone numbers, the information, we should not just send the patient, okay, there will be a hospital, go around the road, it will be there. It's not like that. You have to provide a clear geographical information to the driver where to go and get that scan done so that time is saved. So these are the facilities which should be in this essential stroke care center. Brain imaging and thrombolysis facility. Thrombolysis facility should also be available in the essential stroke care center. Now, can everybody thrombolyze? That is the question. What is the point in having a TPA and CT scan center where there is a neurologist is available? The thrombolytic drugs now available in India, like tenecteplase and TPA, in the pack insert, it says that should be prescribed and given only by a neurologist. Is that practical? Certainly not. We don't have that many neurologists. But a supervised neurology care is what is now being advised and recommended, and this involving a neurologist even by remote access to the patient details has made very significant changes in the treatment. There is also a reluctance on the part of the doctors in the periphery to give thrombolysis because of the fears of medical legal problem, and also lack of confidence and lack of knowledge as to how exactly it should be given, what are the inclusion and exclusion criteria, what should be the post-thrombolysis monitoring, and if a complication develops, how should it be treated? Do we have a neurosurgeon nearby? All these questions are there. So it's good that somebody who can provide either a physician who is trained in stroke care. So that's now the other plan. We need physicians who is well trained in imparting the stroke thrombolysis care at least, and then to identify patients who need a referral to a thrombectomy advanced stroke center. So these things should be available at the essential stroke care center. There should also be emergency protocols in this hospital. Emergency inter-hospital transfer facilities protocols should be available, and the list of centers should be maintained there. They should have who decides what is an essential stroke care center? So this is where our National Board of NABH has started. If you look at the NABH website, there is a very specific stroke center certification. Any hospital can apply for it and either become a minimal care stroke center or an essential stroke care center or an advanced stroke care center. You can be, it can be your own hospital, it can be a multi-specialty hospital, corporate hospital, it can be district hospital, it can be primary health center, government medical colleges or institutes of national importance. All of them need this NABH accreditation. There are also other NABH approved, other certifying agencies are also there. Some of them have been approved by the government or in the process of approval, because the volume is phenomenal. So NABH alone giving all the accreditation to all these centers is actually not realistic. We need to do it fairly quickly as well. I already told advanced stroke care center does need actually a direct availability of a neurosurgical theater and a neurosurgeon, a surgical theater, because big bleeds and patients with a large infarcts who need cranial decompression, these are all problems. And the reversal of the thrombolysis induced hemorrhages by drugs like prothrombin complex. So all these things have to be available. So advanced stroke care centers should have all these facilities, and they should also provide mechanical thrombectomy. To do mechanical thrombectomy, you need advanced imaging, including a DSA, and to deliver that care also, you need a biplane DSA and a trained interventional radiologist, or nowadays interventional neurology courses for acute stroke thrombectomy has also started. And the national board is giving fellowships for neurologists also to become radiologists, neurologists, etc., also to become this certified thrombectomy personnel. There are all these essential and advanced stroke care centers should also mean there is one problem with our country, that even though we are digitally very good in our digital capabilities and skilled manpower, maintaining good databases and to keep registries and the auditing of all what is going on. It should be a routine affair. Every patient should go into a digital setup. Every patient in whichever hospital, not only in big hospitals like JIPMER, but also in district hospital, but also in primary health center, every patient should have, because this data is strength in providing care, in estimating how much of finances are needed to implement a program, how much of manpower is needed. You need information. Information is the most important thing in this in current day world, you know. So and there should also be monitoring of the quality, stroke quality services, and the centers should go themselves to get the certification, and that is going to become mandatory sooner rather than later for every hospital. And there should be a continuing stroke education to all the hospital staff and even to the other health workers and even to the community. So neurological assessments at minimal stroke care center should do vital signs, whether it's a stroke or stroke mimic, to distinguish between TIA versus minor stroke. Essential stroke care center, of course, all these things. Plus, since they are giving thrombolysis, there should be personnel to do the NIH stroke scale. They should be able to subtype the stroke into CSP or TOAST classification. Aspect score, they should be able to do. And of course, the other things like volume of infarct, and also a vascular imaging, not only brain imaging, but also a vascular imaging in all stroke protocol, all over the world, irrespective of whether it is a developing country or developed world. If you are doing a scan for a CT scan of for stroke, it should be a brain imaging and a vessel imaging. So CT plus CT angio, nowadays, most of the machine can do it in 8 minutes to 5 minutes time. So it's only a 2-3 minutes difference actually. And it's also found that even if the patient has medical superintendent is expert in renal problems, it is safe enough to do a contrast CT scan, even in a patient who has got mild renal failure. If there is a non-history of renal failure, of course, we may have to defer it, again, depending upon how well controlled is the renal problem. Otherwise, it is safe. And the medical associations all over the world, not just neurologists or a stroke specialists, have agreed that CT with CT angio is safe enough in any stroke patient, unless it's already known to have a significant renal failure. So, at the advanced stroke care center, we should also be able to advanced vascular imaging, assessment of complications like hemorrhage, raised ICP, herniation, etc., because these are the kind of specific problems that they deal with and impart treatment. So these are the general, there are general principles of stroke care, all acute. All acute strokes should be admitted in the hospital. That is the level A evidence. They need not be admitted for a very long time, just because the stroke can progress in the first few hours. And if you are sure that it's not progressing, it's a lacuna stroke, and it's not progressing, you can discharge the next day itself also. But you never know until the next day, if the patient has arrived in the thrombolytic window, whether because of the natural progression or because of your thrombolysis or your other intervention, the stroke progresses. So it's a good idea to admit and observe every stroke case, at least for the minimal period of time, wherever patient is needed, even if you don't feel it's a major, or if you have difficulty in identifying whether it's a stroke or a stroke, that also will need some time to do that. I'll be so these are the other important principle of acute stroke care is to prevent the complications. And it's very, very important that a swallowing assessment should be done and appropriate management of feeding, fever care, and blood sugar management. This is called the FES protocol, development by a group of nurses in New Zealand. This is a very, very, very important part of stroke care in any acute stroke care facility. Whether you give thrombolysis or not, you give thrombectomy or not, post-procedure, if you do not give sufficient attention to feeding, swallowing assessment, fever care, and blood sugar management, the outcome of stroke can become worse. Or if you do these things, the outcome of stroke can significantly be favorable. So it's equally important as giving the acute intervention. Patients with a significant disability should need low molecular weight heparin to prevent venous thrombolism. Otherwise, when somebody starts physiotherapy, the clots can get dislodged from the paralyzed limbs where DVT has developed and can produce pulmonary embolism. All your efforts of saving that patient would then become waste. So you have to be very make sure that significant paralysis, especially grade 0, 1 kind of power, they should be on low molecular weight heparin as well. And urinary retention, incontinent, constipation, diarrhea are not at all common in acute ischemic stroke. They need proper care in order to reduce the patient discomfort and also to prevent complications. These are some of the desirable care and core care, etc., given at the minimal care center, which are not at all very difficult, can be arranged and organized even in any minimal care center. In the essential stroke area, the infrastructures needed are additionally a cardiac workup and also a Doppler and Holter monitor, ideally. But sometimes the Holter, as you know, are available not even the district hospitals, and they have to come to a medical college hospital. The manpower needed, since you have to give the acute stroke therapy, unless there is a qualified, trained stroke physician, either a neurologist has to be available nearby or through a telemedical support to provide that care. Then the other things like stroke severity rating scale, brain imaging, these facilities should also be there. In the advanced stroke care center, I already told you these points. We have already mentioned. This will be the additional infrastructure, manpower, and the specific cares which are available in a advanced stroke care. Essentially, a neurosurgical support and treatment of complications are very, very important. In addition to the DSA, biplane DSA to the mechanical thrombectomy. I would, so when you, since you are all there, you know that among the thrombolytic drugs, all of you are interested, there is nothing much newer has come in the last 2 years as far as the thrombolysis is concerned, except that now we know that a slightly cheaper drug called tenetiplase is as good as IV TPA in giving the outcome. It's as good, and in fact better, because the hemorrhagic complications are less with the IV tenetiplase. It is cheaper also, and in fact India has taken a lead in the production of this particular molecule. One of the first few countries which actually started using it, and first few countries where the regulatory body gave approval to these drugs. It's a very versatile molecule. It's a biosimilar product of TPA, and that has made things cheaper. And now all the government district hospitals, except in some of the lesser developed parts and states of the country, and all the medical colleges have started giving IV TPA free. Governments have started. It's become an essential drug for acute stroke care. And thanks to our medical superintendent administration, we have also been giving it for the last 5-6 years freely to all our patients who need the treatment, who come within time, and whose inclusion and exclusion criteria satisfy the delivery of that treatment. There are some important contraindications also. Within last 6 months, if the patient has had a hemorrhage, intracerebral hemorrhage, or within last 3 months, any other significant hemorrhage, and of course the various coagulopathies and other. There's a list. It's very important to go through this checklist. And beyond 4.5 hours, up to 9 hours, also you can give. The principle is that whether there is salvageable brain tissue. We always knew that salvageable brain tissue is the most important criteria. And we have now 4.5 to 9 hours, patients with a non-onset time, patients with an unknown onset time, and they wake up with a stroke. Patient with an unknown onset time when they are awake, but they are not able to remember due to various reasons when exactly the weakness is developed. In all these cases, we need additional imaging, like an MRI is a must in this third group, because we have to show a DWF flare mismatch. A CT or MRI core perfusion mismatch has to be established in the other two conditions. And then based upon this imaging criteria, we can give thrombolysis. Coming to the mechanical thrombectomy, the classical window time is up to 6 hours. And these are the very important inclusion/exclusion criteria. You have to be familiar with stroke, diagnosing, its imaging, etc. Only then, so you certainly need a neurologist and radiologist help. Nowadays, there are softwares like Radiant and AI-based automatic reading of the images have actually become the way they manage these acute stroke patients in the developed parts of the world. We still believe that a radiologist visual reporting is important, and we go by that until sufficient confidence comes into use of this automated AI-based softwares. We will follow that as per our guidelines now. So we have the mechanical thrombectomy, and we can even do mechanical thrombectomy beyond 6 hours also to 24 hours. But again, you need multimodality imaging there, and you certainly need a CTP or MRI. The perfusion weighted imaging mismatch has to be shown, and based upon these criteria, you can give mechanical thrombectomy even beyond 6 hours up to 24 hours. Massive strokes will need decompression. It saves a lot of life. People thought that what's the point in saving the life? They all end up with severe deficit. They lead a miserable life. It's a big problem for cranial caretakers, for the society, etc. But let me tell you, people who have undergone decompression craniectomy after about 6 to 9 months, as early as 6 months, are now coming walking into our OPDs, and this is no exaggeration. So it all depends upon how good is the person's own otherwise health, and also how the post-stroke care is given, how early they also get into the program of rehabilitation, etc. And as long as we take care of the general health, very good recoveries are found a reality. So it's important to take care of patients with the massive strokes also. You can see that the surgical interventions like decompressive hemicraniectomy, ventriculostomy, and decompressive suboccipital craniectomy, and sometimes continuous ventricular drainage. All these things are very, very helpful. And that's why a neurosurgical support has been repeatedly emphasized in the Advanced Stroke Care Center. So we must have these competencies. So, and these are the important quality measures. Suppose you have an essential stroke care center. How do you monitor yourself? How well you are doing? How well you have improved your services over a course of time by better training? Is by looking the time. Of course, time from stroke is not very much within our hands, but it tells about the stroke care services the health system is providing to the individual, and also to the awareness as well as the economic status of the country in general. Time from stroke onset, proportion of strokes who get a CT scan within 1 hour of hospital arrival, and also within 24 hours, because all these are happening in reality. Proportion of strokes which are assessed for swallowing deficit. See how it's important. Assessing for swallowing deficit is very important to prevent aspiration pneumonia and death. You can see in the mortality meeting, a lot of deaths are finally happening because of the pneumonias and then septicemias. So assessment of the swallowing is extremely important. Proportion getting IVTPA, proportion the door to needle time, proportion who receive acute endovascular therapy, time from the hospital arrival to arterial aspects, proportion of patients who receive acute aspirin therapy within the first 48 hours, and also the system indicators like the availability of TPA medication and endovascular services in the region. All these are important in deciding the stroke quality, and these are the stroke quality parameters. Remotely supervised stroke care centers are possible. Telemedicine supervised services are going to come up in our country in a big way. We all have the Google Maps of various services, which are the best hotels in Pondicherry. If you ask, the Google Map will give all these hotels. They will also give you approximate charges of 1 day stay in each of these hotels. So why are we not having which hospital can provide which service? So this is possible. You need some kind of accreditation of the hospital, some kind of assessment of the what levels of capacity Each of the hospitals are heavy. Every hospital can do. We have there is lots and lots of patients who all need care, and hence every hospital needs the accreditation. Then only they will also think of improving themselves. So just like we have hotels, facilities available at different rates in the country, we can also have accredited stroke center maps in the future. So these are the hospitals in Pondicherry, but we don't know exactly at what level an acute NCD care is provided in each of the hospitals. This is what the government is now working on. Already the process has started. And if you look at the stroke, if you look at all the NCDs, stroke and coronary syndromes, these are the ones which need immediate attention for immediate saving of the life. So that is why accreditation of stroke centers and coronary centers are in the NABH. You don't have to get the entire NABH accreditation. You can specifically go for a stroke center accreditation or a coronary center accreditation. So, and telestroke therapy is very important. I won't be going into the detail, but they can provide acute recommendation regarding TPA use, and in fact, with the very good digital services, online services, we are able to even read the images done in periphery also, and give robust advices as to what kind of care, whether this patient can be treated in that center itself, or he should be taken to a next CT center. Oh no, this is a very big info. You directly take it to an advanced stroke care center like a medical college or a JIPMER or any other corporate hospital. Because it's unlikely that the hospital with only CT scan will be able to provide the kind of care. So this information can be provided by telemedicine care. So there are some case scenarios. I'll come back to it if you have time. There are also some concerns about suppose something happens, a patient develops a big bleed. Who is responsible? Is the local physician or the person who is giving the care advice from the telemedicine, or the person who provides the kind of imaging service or the online service is responsible for? So all these kind of legal issues are there. These are being sorted out. So this in the hub and spoke model, the detection is important even at the layperson level. So it can be a school student, or it can be a young man recognizing in his father or in a neighbor. Then the EMD caller communication, the emergency medicine assessment, and deciding the destination where the patient should go to a next place, a radiology center which does only a CT scan, or to a medical college, or to a district hospital. So that EMS assessment and destination decision is very important in all your practices. And the stroke center certification standard and the stroke care networks. So this is all in the hub and chain model. And from the bigger centers like INIs or medical colleges or district hospital, the patient also has to be referred back to make sure that the secondary prevention is continued, or the stroke follow-up care, detection of complications, and the care or referral back to the advanced center. All these things happen in a very smooth way. So that is why it's a win-win situation, mutually beneficial to the hospitals outside as well as to the main center, which won't be overcrowded, and also, of course, to the patients. So these are the awareness on recognition and its management are important, and the treatment and transit, pre-arrival care, notifying the patient, the center where the patient goes in advance to keep a bed ready, to arrange a ventilator or some other life supporting measures. All these, or get the intervention ready to come in the night and be ready to in the angio suite to take up directly into the mechanical thrombectomy. So all these communications and coordination is also extremely important. And it was found that because of the pre-hospital management, actually the outcome of the stroke, they looked at the favors, control favors MSU. What was found that pre-hospital management and mobile stroke unit compared to conventional mortality at 30 days hasn't actually significantly changed. mortality hasn't changed significantly. If you look at the IV thrombolysis, extracranial hemorrhage, there was a concern that if you give thrombolysis on the pre-hospital, whether it will increase hemorrhage, but this was also not statistically significant. So the two-way nature of the hubs, I already told. So to conclude on this, pre-hospital care has the potential to significantly impart overall acute stroke care. There are emerging technologies allowing more advanced pre-hospital evaluation and treatment. Implementation of the current and future innovation EMS systems are important, and pre-hospital care provides continued promise of coordinated hyperacute treatment of patient. This is not my concluding slide. I have something more to tell about rehabilitation, but I won't go into that. If you have time, later on we'll discuss it during the panel discussions. This is important. Key developments and concepts in stroke care. What are the new developments and newer concepts? Thrombolysis and potential windows of expansion. You all know about it. Thrombolysis is available and it is effective and it is safe. And there are potential windows, periods of expansion. Mechanical thrombectomy for acute ischemic stroke is a very, very powerful treatment for the right patient at the right center. Life-saving cranial decompressions are possible and are necessary in patients with a very large infarct, and you should not worry much about what will be the burden to the society and to the family or to the person himself if he survives. Carotid angioplasty and carotid endarterectomy for the secondary stroke prevention, very powerful, very effective methods to prevent strokes in somebody who has a minor stroke or a TIA, not major stroke. Once somebody had a major stroke, even if there is a significant stenosis, you don't advise any endarterectomy. If you had a minor stroke or a TIA and there is a significant stenosis, carotid angioplasty or radiologist can do, or the surgeon can do. Very early surgery is better, actually. Looks paradox, but carotid endarterectomy is the better treatment for a significant stenosis for the first 1 month. Beyond first month, both angioplasty and endarterectomy are equally helpful, but there are some other criteria also to select between these two. And there are genetic markers of cardiovascular diseases. We won't go into it, but it's good that if there is a family history of strokes and all, those people should be screened for the risk factors, and they should avoid lifestyle habits like smoking and alcohol, etc., etc. And newer anti-diabetic and lipid-lowering drugs and newer anticoagulant drugs have really improved how well we can treat care. That's why some of the previous advantage of endarterectomy, etc., compared to medical treatment has to be re-looked into now because we have better medical care available now. Stroke center classifications, accreditation as to where the different kinds of care should be given. All patients should not be rushed into to medical colleges and other INIs, etc. And two-way hub and spoke model of management of patient. Telemedicine supervises remote acute stroke care and even stroke rehabilitation. Telemedicine supervises tele-rehabilitation. These are all very important care. And long-term home care is also very, very important. And of course, I think we will email a copy of this for you to have an idea. It's very difficult to right now try to grasp and memorize all these things, but it's quite a very, very useful kind of algorithm for any physician, including neurologists and stroke physicians. So this is my last slide. Take-home points. Early recognition of stroke is of paramount importance. Need for vigorous campaign on treatability and time component. All of you should take it up as a mission to tell patients coming to you with minor problems, patients coming to you with a totally unrelated medical problem, and also the relatives to tell the importance of lifestyle modification, the importance of recognizing conditions like acute stroke and acute coronary syndromes and other acute, depending upon what other medical problem they are having, how an acute critical life-threatening condition can develop in them, and then what to do. That you should always advise before they develop any of those symptoms. Organization and accreditation of stroke care centers and other acute NCD care centers. Thrombolysis or beyond 4.5 hours are possible, but only in advanced stroke centers. Endovascular therapy up to 24 hours is possible, but only in advanced stroke centers. Awareness and integration of stroke care centers of different levels are important. Every community doctor should have a map, just like we have telephone directory. Which are the different levels of care? Which hospital? What is the telephone number? Who is the contact person there? And what is the mechanism you can think of in quick transportation of your patients? There should be a protocol already and contacts, numbers, and available. Post-stroke care is also very, very important. I told you how much it changes actual treatment. Simple things like taking care of swallowing and fever, etc. And protocols and documentation important at all levels. We have to develop this habit of documenting every one of your patient and continuous of documentation of further developments in the patient for their care, for your own auditing, and also to help our country, its healthcare delivery system as well as the science.
Yeah.
Thank you.
Thank you very much, sir. Thank you very much. Questions, we'll have it at the end of right session, like during panel discussion. We welcome our IMA President, Dr. Sudhakar, sir. A few words from him.
Good evening. Sorry to be late for this session due to some emergency case. So I welcome you all for this wonderful CME program on the Sunday. It was really. I also welcome Professor Durrajan sir, who is our urology part, and we are very known to us, and is also a mentor guide for us in various occasions. Welcome you, sir. Next speaker.
Yeah, thank you very much, President. Sir, as a medical officer in the primary health center, just only one question, sir. So I'm just seeing my patient, right, diagnosing it's a stroke patient, and the patient BP is more than 220/120. And what I'm supposed to do, like at the primary health center, right, we have like nifedipine sublingual to be given or not, or any other antihypertensives to be given to reduce the blood pressure before we refer the patient to a higher center. And what are all the precautions should be taken before we refer that patient to a tertiary care? Please, sir.
So this patient with a 220 systolic in a
220
yeah,
systolic pressure, 120 diastolic, more than.
with without any other
With the all
with
features
stroke or
of
something, or
acute stroke.
acute stroke. So suppose the patient is in the thrombolytic window and you have a facility or access to giving thrombolysis within that window period. We are, yeah. So no, what I'm telling is about the BP management, whether we should
No, what
immediately
is being
control it.
asked is what should the primary health center doctor do? Should he immediately refer? Should he control the BP, watch for 15 minutes? Should he give antithrombolytic drugs? What should he do?
If the patient is in a thrombolytic window, the priority is giving in thrombolysis, but you can give thrombolysis only if you are able to bring the BP below 180. Only then we can give TPA. So transferring the patient to a center where thrombolysis and CT is available, as well as bringing down the BP, has to be done simultaneously if he is in the window. If he is not in the thrombolysis window, then the BP lowering has to be a little more guarded. You don't have to drastically reduce. In fact, it is harmful to bring down the BP very quickly if you are not thrombolizing. It's better to allow the BP to be slightly on the higher side, unless it is a hypertensive emergency. If you are seeing bleeds in the fundus, and if the patient is in altered sensorium, and if you are suspecting something like a acute hypertensive emergency, then you have to bring it down.
So
Otherwise,
would it be a fair statement that if the patient is within the thrombolytic window, give antihypertensives and then refer, like sublingual nifedipine, or if it's outside the thrombolytic window, immediately refer unless the patient is having
hypertensive emergency like
hypertensive emergency like situation, but would not 220/120 be a hypertensive emergency like situation?
Not all 220 should need be. I think
Okay.
Dr. Yeah, Yeah, there was a very specific slide also. In thrombolytic patients only, you have to bring it down below that specific ranges. If the patient is not having a stroke and his BP is high, then we should reduce even if the patient is not in thrombolysis, not in hypertensive emergency. But if the patient has had a stroke, it's important to maintain sufficient cerebral perfusion pressure. And hence, we should not be very aggressively reduce the blood pressure.
So 180 by 100 or 160 by 100 will be sufficient.
Yes, definitely. Now, we should never bring it down below
yeah.
180 if it is not in the thrombolysis window.
It will affect the perfusion.
Yes, absolutely.
Thanks.
If it isn't the thrombolysis window, then should we give the thrombolysis while simultaneously controlling the BP, or can the primary care physician control the BP and then send the patient half an hour later to the next center for thrombolysis? What is your recommendation?
We should start the BP lowering measures, but before the drug is injected, the systolic BP should come below the level.
So the primary care physician should start antihypertensives
Yes.
immediately and then refer.
Yes, if
Is that a fair in the thrombolytic window? Is that a fair statement?
Sir, in the periphery center, sir, only
instead of-
telmisartan
instead of-
amlodipine is available, sir. Not nifedipine is nowadays not available. What drugs can we give? Only available telmisartan and amlodipine in primary health center or even in clinical medical store also. Nifedipine nowadays not available, sir. You are telling nifedipine. So what drugs we are taking?
So they say sublingual nifedipine is not a good choice. What about injection labetalol, which reduces gradually?
It's
Or
not available. No, that's what is
Laboratory
the
not
problem
available
is-
in primary health center.
Yeah.
no.
So this is indeed a problem. But if you are actually a facility with thrombolysis, for example, essential stroke care center, every essential stroke care center should have an anti-hypertensive drug. In fact, you brought out a very important point. I have not emphasized in my slides. I'll make sure that this is added on. In every essential stroke care center where thrombolysis is to be given, there should be BP lowering drugs which can quickly reduce the blood pressure, like IV labetalol or nifedipine, etc. We cannot have only amlodipine or enalapril, etc., because they won't bring down the
Yes,
BP that fast. Very good point. And this is something, this is all, that we are still reaching the peripheral, and where to give what is still being sorted out.
Still we are only
Important
talking,
point.
sir. It is not coming to the practical.
Yeah.
So rather than
See-
labetalol, if a patient is having a bronchial asthma and other this one, contraindication will be there because alpha beta both this. So esmolol, what about the esmolol? We can control it's having a half-life of 10 minutes and this immediately. So what is the role of esmolol?
I think Dr. Vivek will be the better
See,
person.
This is also, yes, please.
Yes, sir. It's an important problem. I think our primary health centers are not equipped to manage the hypertensive crisis. So I think we need to say there are two options, as rightly said, labetalol, which we use here. Esmolol also we use, but less frequently because labetalol is available. I think between the two, esmolol will be ideal because there is a minute-to-minute control. You can always stop and the effects are reversible within minutes. But it is not. But I think it is not difficult for a country like India to make esmolol available for this purpose. I think we have not put the mind, we have not made the efforts. It can be done. It can be limited to certain indications. That is one. And sublingual nifedipine is something which drastically reduces. So it is absolutely contraindicated when there is a stroke or MI. So sublingual, even if it is available, we should never use. Such a drastic and unpredictable reduction is not recommended. Ideal drug perhaps is labetalol or esmolol, or a fast-acting calcium channel blocker will be ideal because you don't have to worry about the asthma or other unexpected comorbidities, but I haven't used also. So I can't say from personal experience, but there are nitrindipine, nicardipine, those intravenous calcium channel blockers we can consider, and maybe in a country, I mean,
All the
state like
IVs
Pondicherry, it is
IV
eminently
sodium
possible.
nitroprusside, IV labetalol, all
What-
those
Those
things.
things should be
What
Oral
about
nifedipine also can be used, but not sublingual.
What about NTG, sir? Infusion,
Like-
suppose in case.
Generally
because-
considered not advisable because of the venodilatation. ICT could go up. So it is preferably avoid.
Nicardipine is available now, sir.
I haven't
It
used
is
it.
in fact one of the drugs which has been recommended for reducing the BP to the thrombolysis level. Nicardipine is also one of the.
We generally use Libitalol. So I think
not very
consumer doctors are fine.
frequently
Should be
available
fine.
in India. It's not all that. It is
So-
very more commonly used.
No, my question is very simple. See, the primary healthcare center doctor is measuring a BP of more than 220. Should he refer with that BP to the higher center? That's it.
Sir, this question I asked 3 months ago in the month of September during cardiology day to Dr. Chenniappan was there in our IGMC. The emergency medicine chief was also there. What they told was, what is happening now? I'm a PhD doctor, served more than 13 years in the peripheries. We give all patients with malignant hypertensive, amlodipine 10 milligram and send them. What he says is it's not going to drastically bring down the BP. In fact, you're going to do more harm. Do not give anything. It is not going to matter. They will not sue you also. Suppose if I don't give any drug, say amlodipine 10 milligram, and if I send the patient with a high BP, with a diagnosis malignant hypertension, will I be held? I asked him. He said, nothing will happen. You just send us to emergency medicine because time is brain, time is heart also. He can go for both problems, complications. You just send him fast. We will take care. Because even if you give.
So you are talking about patients with this high
Yes.
BP with either a coronary syndrome or stroke.
Yes, sir. What he says is you may give only 325 milligrams of aspirin with 60 milligrams of atorvastatin and 300 milligrams of copilate.
You're
So
talking
that,
about
that
cardiac.
combination you can give, but do not bother about the high BP. Just send them. Nothing will happen. If anything is happening, we are not to be
It all depends
responsible.
We are
on the
not-
window period also.
That's
madam.
what is
Suppose there is only half an hour for thrombolysis and the patient is already having such high BP, we have to bring it down below the thrombolytic window BP level.
that drastically, he says, because IV labetalol is the only panacea. So unless he comes to the ICU setup, it is dangerous to give, he says.
Dr. Kaveri, we are talking about brain attack.
Yes.
It is not cardiac attack. Okay. So
Patient from say Mannadipet PHC to JIPMA, if you give IV labetalol, are you okay?
see, malignant hypertension.
That also is a problem.
Malignant hypertension with stroke or without stroke?
Without
Next.
stroke or with stroke, not to give IV labetalol
No, no.
from the PHC setup. That's what he said.
No, I'm asking you very simple question. Malignant hypertension, you are seeing that patient with stroke or without stroke?
With stroke or without stroke, do not give. That's what I'm saying. That
When
is
you are
what we
talking
are told.
about aspirin and clopidogrel, what is that?
That you give for coronary, acute coronary
So
attack.
that is a cardiac heart
Yeah.
attack. So don't bring clopidogrel and aspirin.
What we want, sir, like you told, if you give thrombolysis for stroke, it is very effective within the window time. Can PHC doctor also do that help for you? That's what he also want to know. We are keep on talking this for so many years we are talking. Even in Yanam GH, sir. So can the PHC doctor give thrombolysis?
Listen, you cannot, there cannot be dogma in this. It's very straightforward.
So only shifting the patient in time is the option for us, sir. That is all we can do.
Thank you very much. Let us all discuss in the panel discussions. Right. Our next topic actually, like Dr. Manu Ayan sir, he is out of station. So he'll be through online. He is going to talk on pre-hospital and remote supervised care of acute stroke. He's a department of he's a associate professor, Department of Emergency Medicine at JIPMA.
Good afternoon, everybody. Am I audible? Am I audible, sir?
Yes, sir.
Uh, so just let me share my screen. Is my screen visible, sir? And am I audible?
Yes, sir. You are audible, sir.
And is my PowerPoint slide visible, sir?
Yes, sir.
Yeah, thank you, sir. On this offset, really sorry that I was not there. This was a prior commitment which I had made, and the request for the talk came a bit late. But I'm really thankful for IMA and the organization, and as well as the neurology and medicine team to actually invite me to have a session which we are really working on. I think Sunil sir has actually made my job easier by actually touching upon key pillars of pre-hospital strokes care. But I will actually, try to touch upon some of the core elements, and also, throw some light upon what sir was trying to tell, that we are working in ministry to actually improve systems of care, especially improve systems of care in stroke. So this is the landscape of emergency burden in our country. If you look at NCDs are a big part of mortality, and the landscape has really changed over the last years, and it's still changing. And it actually amounts to more than 3% of our GDP loss. And this has been actually come up as a big issue. And then that is where ministry started looking at these core acute emergencies which needs to be managed appropriately at various levels of care. As we have already rightly told, and everyone understands that faster care is the best care, and every minute lost leads on to mortality and morbidity. And if you look at stroke care, this is from my AHA, that they tell that if 1 minute is saved, 1.8 days of healthy living are saved, and 15 minutes is saved, 1 month of healthy living is saved. And that's the importance of giving very acute right care without wasting even seconds for stroke. So what is pre-hospital care? This is something very misunderstood across, especially across our country. Probably this term actually has been understood in other parts of the world much better. There are definitions of pre-hospital care being defined as before reaching any healthcare facility. There are definitions which tell pre-hospital care is basically before reaching a definitive care. So they've traveled across 2, 3 health facility, but when they reach the definitive care, that is when the hospital care happens, and whatever before that is pre-hospital care. And ambulance care is also technically EMS. EMS is emergency medical services, which if you Google, the first thing which comes out is pre-hospital care. Somehow in our country, in some part, especially in southern part, EMS is called as emergency medicine, and so there's a lot of confusion. But technically, basically whatever happens before a healthcare facility, a patient reaches a healthcare facility, is technically defined as pre-hospital care. Now, components of a pre-hospital care is basically three. You can see the core components as a call center, an ambulance, and then they're connected to a hospital. So these are connected by information systems, training, and health education, and the overarching is the legal framework for them to function, and the governance mechanism for a best pre-hospital or EMS system. So in India, we have basically two systems which has been, and we have been trying to unify it. Unified system of 112 is coming in our country, and funds has been allocated, and Pondicherry is also developing that unified call center system in Director of Health Office. But if you look at 108 and 102, and across the country, there are around 17,000 government funded ambulances which has been deployed across the states. 108 now, majority of it, and around 20 states, if I am right, is run by a PPP partnership model. And command centers, all what we call the call center or the dispatcher care, is run by again a PPP model. As of now, none of our healthcare facilities gets a pre-arrival notification, apart from few model states like Tamil Nadu, which do get pre-hospital notification, especially in trauma and stroke and STEMI. Government actually had been, really pushing this in for the last a decade, where around yearly around 200 to 300 crores has been going on from the central ministry in the state's PIP budget. And if you look at this is actually really a small amount. If you look at to actually man these fleets, this is around, if you imagine around 10,000 fleets minimum. For per ambulance, if you calculate the cost of around 15 around ish for ambulance, we need around 70 crores to be actually being spent to run effective pre-hospital care system, which we are seeing in developed countries. Now, this is a framework which really defines the emergency care, and this is the emergency care system framework which has been put out by WHO, which WHO clearly told that all member states, especially low and middle income countries, really should focus on these three pillars, where on-scene care, transport, and facility care needs to be improved. So they have been really pushed towards building research, building and funding to each of these areas. So if you see, it's a very nice, very crisp infographics really telling about how what a bystander would do, what a dispatcher would do, and once the dispatcher calls the ambulance provider or the what we call the emergency medical technician, who is trained in managing acute emergencies, come, they take this patient, provide en route care, document, transmit the information to the receiving facility, and the hand over the patient to the receiving facility, and the receiving facility does the appropriate care. So this is in essence in the 72nd regulation of WHO, this was told, and from ministry in Niti Aayog and Government of India has been working on to develop such a system across the country. Now, coming to stroke, pre-hospital stroke scales has been really helpful. This is something which I think Sir had also talked about. These are scales which are developed, which has been developed and looked at. So pre-hospital stroke scale is something which we use to actually detect stroke. Now, BFAST is something which is being actually propagated across our country, which includes balance and eye, because this was actually the FAST, which was initially told as a mnemonic to basically identify stroke in pre-hospital, was not very specific to get posterior circulation strokes. So that's why BFAST has been, now being propagated, and there is research to tell that this will be much better than the other. After the stroke screening is done, we need to do something in pre-hospital called stroke severity scale, where the pre-hospital care provider or the EMT, what we call, decides on whether to transport this patient to a facility which is capable of doing endovascular care. So there are multiple stroke severity scales which has been developed, but on essence, these are not really spot on. These are all developed kind of like subscales of an IHS stroke scale, which is really extensive and might not be really possible for a emergency medical technician to do. So these are few scales which has been now regularly used by developed pre-hospital care systems around the world, where LAMS is something very popular, and RACE is something very popular, and VAN is something very popular, which has been used across different pre-hospital care systems. Now, the idea is that I think the slides are also was trying to project. This idea is that once you have a patient who is scored on top or very severe cases, 3 to 5 points in on majority of these scales, this patient actually has to be taken to a facility which has a capability to do endovascular care. So this is a very simple algorithm which is being used in developed countries where stroke is identified, stroke screening is done, EMS dispatcher is called, and they send the EMS teams. They does the stroke screening. After that, does a stroke severity screening en route in the ambulance, and actually decides on if the time of stroke is within the first 6 hours, then they actually transfer this patient to the nearest stroke center. So you can see on the right side what is the permissible transport time required to transfer these patients. And if they are inside that window, they transfer these patients to a stroke center which has an endovascular care. Now, this is something which we did. We were also part of this assessment, a countrywide assessment. This was funded by Niti Aayog. Along with All India Institute, we surveyed 100 institutes across the country. We also surveyed few institutes in Pondicherry also to actually understand how various emergencies are being dealt with. So if you see, 91% of all hospitals had in-house ambulances, but lacked trained paramedics to man these ambulances. And the provision of specialized care or the so-called specialized ambulance systems were not there. And the pre-arrival notification was really lacking in all these facilities. So this is one of the documents which actually is now being used by ministry to pivot certain fundings, which is now coming through. Now, dealing with specialized ambulances, I'll just show you how a specialized ambulance will look like. We have multiple different vendors doing it, so there's no conflict of interest. I'm just showing you how this will look like. Hope the video or
be reached. So the ambulance is loaded with connected biomedical devices like the multipara monitor, which transmits real-time heart rate, oxygen saturation, respiratory rate, 5-lead ECG, blood pressure, ETCO2 and IBP to the control room via 5G technology. Unlike all other ambulances, we are having a provision to do a real-time ultrasound inside the ambulance, which can be transmitted to the control room in the hospital. And we are having a digital stethoscope which actually captures the lung sound and heart sounds, transmits to the control room. Being a scientific ambulance, we have made our best efforts to make it 100% format free, which means it doesn't have any curtains or papers. Instead, it works with voice commands and smart windows which turns opaque by a click of a switch. India's first assisted reality tag comes from the Epoch Smart Eyewear that's there inside the ambulance. With the help of integrated cloud-based software, the senior doctor can see, control and diagnose the patient with the help of Epoch smart glasses. Crash cart door is designed in a way that it is disaster specialized. The door, when it's opened, it gains all the emergency medicines and first aids that's needed for any patient that's there in the disaster zone. Where the structures cannot reach, the deployment wheelchair can be used to shift the patient and rescue them from stranded areas. The built-in air suspension makes the journey jolt-free and comfortable and restricts the movements inside the ambulance for the patient. It has the maximum space utilization by using jump seats which are front-facing and reduces the chance for nausea and vomiting for the passengers who are inside the ambulance. The smart plates inside the ambulance lets the junior doctor as well as the senior doctor in the control room to triage the patient and convey the information to the traffic control room so that the ambulance won't be misused in.
So this is kind of a specialized ambulances, which is like, in our country, which is called 5G ambulances. There are multiple vendors who does it. We also, along with the Ministry of Health, is trying to push this across our district and state also. We are looking for some CSR fundings where we are looking at actually deploying these, around 4 of these in Pondicherry.
Be reached. So the
Now, mobile stroke unit, which sir was talking about, it's not that we actually, one of the first mobile stroke centers stroke units was by Kovai Medical Institute. And the second was in Tejpur. So I'll just show you how a mobile stroke unit works. And this is inside our country. It's not in any other parts of the country.
Is funded by the Indian Council of Medical Research, ICMR, and aims at establishing care pathway for acute stroke using a mobile stroke unit. The uniqueness of the mobile stroke unit is that it is an ambulance equipped with a CT scan machine, portable laboratory equipment, and facilities for telemedicine communication with specialists.
Research have shown that in Assam,
1/3 of population and 2/3 of T tribes suffer hypertension. Untreated hypertension leads to stroke. Other risk factors include diabetes, high salt intake, and tobacco consumption. Some of the early signs and symptoms of stroke are drooping of face, sudden onset weakness of arms and legs, especially on one side, slurring of speech, sudden onset severe headache, giddiness with inability to see or communicate properly.
Once we receive a call on a toll-free number from a patient experiencing stroke-like symptoms, the ambulance gets dispatched immediately. Paramedics in the mobile stroke unit assess the patient, connect them to monitors, start IV lines, and draw blood samples. After the CT scan is done, they communicate to the physician through teleconferencing.
Sir, this is a 50 years old gentleman with right-sided weakness since 9 a.m.
Through telemedicine, we see the patient in the ambulance and make their assessment. If treatment is required, it is done in the vehicle. We are assisted by a team of neurologists from CMC Ludhiana and AIMS New Delhi. Evidence shows that intravenous TPA, a clot dissolving medication, can be used up to 4.5 hours within the onset of an ischemic stroke. We significantly reduce the time to therapy by bringing everything to the patient.
The mobile stroke unit gets the identified patient to the hospital where further treatment of acute stroke is continued. This saves lives and reduces disability after a stroke. We aim.
So this is something which is happening in our country. This is being MSU has been running for last 2 years. So there are challenges. This is now going in research mode. But one of the major challenges I think which Covey also faced was the roads. Indian roads might have problems with the CT scanners. See, one of the core elements of the scanner actually gets destroyed when actually they goes through our road. So the current MSU systems, what they do is they have this feeder system where the initial ambulance goes and picks up this patient who is actually really in a remote area where the roads are not very good, and then they bring them onto the main road, and from the main road these patients are taken to the MSUs and transported to the facility. So from once the patient gets onto the MSU, the care starts. So it is kind of like inside an emergency department. So this is something which is happening, and this is something which is being coming up. But this challenge really remains because these scanners might not be roadworthy for our Indian roads. So that is where some new research has been coming in. So these are two new researchers coming in from Australia, where these are CT scanners built on kind of a different technology, which actually can be, it's very really small size. The other one which you saw can only be housed in a very big Bharat Benz ambulance, which can take a lot of weight. So these are very lightweight scanners which can be used. So this is something which is really coming up, and probably we'll see in another few years, probably this getting started, clinical trials starting on this one. There has been a lot of push by ministry in improving stroke care, and what are the role and responsibilities of each of the teams working at various levels of care. So this gives a legal framework, also legal protection of what they should be doing, and some of the questions I think which was asked also probably has answers in this document. This is a national plan for stroke has been developed, and this is something where funding is also there in P states PIP to put for training and IEC materials, which I think including our Pondicherry state is also putting. The PIP is actually publicly freely available for all of us to understand how much funding we are getting, but this is there. So this defines what a role of an ASHA, what a role of an ANM and PHC doctor in managing stroke is. So this is something which I would suggest everyone to go back and read. So telestroke is something which has been coming up, and sir had touched upon it very nicely, that it's the way forward, because the number of specialists in our country, especially neurology specialists who's actually looking interested in stroke care, is very less. And this is where telestroke comes in, and it empowers physicians who are working in primary, secondary, and tertiary centers to start thrombolysis as soon as possible. This is an initiative now being run by again by ICMR and AIMS Delhi, which is called the Smart India app, which they are actually now trying it out in few of the states in our country to see if this works. So this includes acute stroke care, which is kind of a tele-driven thing, where there is a group of neurologists who are experts who are empaneled inside that, and the primary care physician can deliver care under their guidance, which is actually again legally protected by our India's telemedicine guidelines, which came in thanks to COVID. The legal framework is there. Now, regarding stroke and community level, as I told earlier, one of the major chunks is awareness, and increasing awareness is something very important. So on the right side, you can see stroke 111 and 911, which has been tried in various parts of the world like China, Africa, and US. So similar things is also happening across our country. On the top right, you can see the video, which is actually developed by Ministry of Health. It's still to be released. We were part of the vetting agency to do this, but then this is something which is actually being tried to bringing out. So basically, so that patients can understand the stroke signs and symptoms and immediately come to a center which can manage. Now, apart from that, we have also modules being developed for ASHA workers who could also propagate awareness of stroke and what stroke symptoms are. And probably in some parts of our country, they are the first responders. So training these first responders are very important. And that this is NHSRC's ministry document, which actually is a training module for ASHA workers. And stroke is one component inside that. Now, with ministry, we have been very keen on improving training, and we were actually able to develop the National Emergency Life Support course for paramedics. This is the pre-hospital care providers who are in the ambulance. So we developed this around 2 years back, which actually covers all the acute emergencies. In that, stroke is also there. This is a module which is funded by ministry. The whole training program is funded, including the travel and stay for whoever comes for training. We did the first training for all the government doctors, like around 30 government doctors and nurses were trained as trainer of trainers to actually implement this in our district last month. This is under disaster cell of Ministry of Health and Family Welfare. Now I will just show you what we are working on and what we should be expecting in the near future in our district and across the country. We are working on developing a model which actually takes care of emergency care at the level of community, where we are trying to develop systems of care to improve awareness, improve training, developing application which would trigger a response as soon as an emergency happens. We are developing a model which looks at pre-hospital care, improving on-scene care and en route care. We are also developing a model which actually is based on health system approach, where we are trying to see if we can improve the care which is delivered at facility. So this is something which we are working on, where ministry has tasked us to actually 5 districts of the country was selected, and I'm really happy to tell that Pondicherry is one of that districts where we got this opportunity. We are working along with Director of Health, MD, NHM, and the state health officials to actually implement this model across the state. Just a sneak peek of what we have done till date. I think Sir was talking about Google showing shopping locations and the hotel locations. So we also have been working on this, and we have brought about basically geospatial mapping of facilities. So this on the right side, you can see both rural and urban PHCs and CHCs in our state. And also what we have done is these are places where we had a systematic sampling. So we went across Pondicherry district, surveyed around 6,000 households, that is around 20,000 people, and asked them within the last 1 year whether anyone in your home had an emergency. Now, we were amazed to find out this is the statistics to around from around 17,000, which we have analyzed till date, we had around 272 emergencies, and stroke is one of them. We looked at if these patients reached the right place at the right time. So this was based on facility grading, and we looked at if they reached within the 4.5 hours of what a patient should reach for thrombolysis. And we found that for stroke, it was only 42% actually reached this facility, even though we have more than 5 to 6 tertiary care centers in our region, and we all our patients are in very close proximity. So this is something which we need to really introspect. And this is the annual incidence of stroke in our district. So this is from community level for the last 1 year, how many had a stroke. So or totally 14, and you can see the locations where they had and the locations where they went first when they had a stroke. So then we graded these facilities. So we did extensive surveys where we had, like sir was talking about, NABH grading. We also had a nationally vetted grading system where each facility is graded based on their availability of drugs, availability of equipment, availability of manpower. And so this is PHC level grading, where we have level zeros is the lowest grading, and level 1, 2, 3, and 4 is the highest grading. This is only for stroke. So for each diseases, grading varies. So this is overall the grading for PHCs. This is the grading for CHCs. We have 2 CHCs, Manadipet and Curriculum. So they are at level 2. And level 3, we have IGMC and IGGH, and level 4, we have, JIPMA. So because why level 4? Because we do endovascular care also. So now this is just for just we have started working on this. There are multiple layers of geospatial mapping which we are doing, and multiple iterations being done to basically iron this out. But this is what is coming by the end of this initiative, because this initiative is really closely monitored by Health Ministry and the Health Minister himself every 3 monthly. So this is what we are trying to work on and bring about in Pondicherry. So this is how a patient walks through when they have any kind of emergency in our districts. You can see how the referral patterns are there, how these, so all these 272 patients who had an emergency, where all they went, from one center to what center, and finally where they went. So this is what it is. So, ultimately coming to we have miles to go before we build an integrated emergency care system. We have been trying and really thankful for all the healthcare providers from PHC, CHC, and Ministry of Health and everyone to actually try to, because have the vision to change, because this is something which we were blessed in Pondicherry, and we're still blessed in Pondicherry. And as I've told, we are really working on building specialized ambulance systems to improve pre-hospital care, and also building in a best emergency care system in our country. Thank you.
Appointed a few years back, right, by our health secretary. So I just went through all the ambulances at Pondicherry, and hardly like 3-4 ambulances only equipped completely with or in working condition, the defibrillator or a ventilator. We don't have a regulatory body here at Pondicherry controlling all the ambulance, or someone has to supervise the ambulances inside the ambulances, whether all the equipments are in a functional status. And there is something they are dictating the terms here at Pondicherry, all the ambulances. So first we have to rectify the basic ambulances or advanced care ambulances here at Pondicherry. There is Really, I'm worried, right? Being an anesthetist, being medical superintendent here, I've been watching here all the ambulance right from the COVID time, where they were dictating terms as well as money, all such. I don't want to raise all those issues, but still, before we could talk about the specialist ambulances, we are not. I mean, we were not able to control the regular ambulances here at Pondicherry. This is, I don't know.
Yes, sir. I'll just throw a light. I didn't talk about it, or I didn't want to bring it up as a big thing. So we surveyed all the 108 ambulances, sir. So as you rightly told, all are level Bs. So basically, level Bs are even basic BLS level ambulances. But one thing which has really come about is there are so these ambulances are I think around 10 or 12 are there, which actually are almost near the end of life. So we actually talked to these people. We went and did focus group discussions with drivers, paramedics who were working. We also visited call center, which is actually housed in Director of Health Office. We have a specific nodal officer looking for taking care of them. Yes, we are different from other systems. Why? Because we don't have a PPP model. So if you look at around 20 states in our country is being run by a PPP model. Our state, our district, basically at state, actually is run. The ambulance system is run by state's own. Now there is debate whether it is feasible. There is how much money we have to spend from our ministry pocket, which is all our GST, which is being spent. But then one good thing which is happening, sir, I think you would also know that 10 ambulances are now have been purchased by AGMC, which is going to be donated to state, which will be transferred to the 108 systems. So that actually is ALS level ambulances, which the purchase order has gone. Probably we are expecting in another 2 months. So this is something which has happened. And also, I think state is actively looking at possibility of PPP model, and also actively looking at possibility of having more ambulance drivers under a contract basis or whatever. I'm not really spilling out everything, but then clearly trying to tell that I think there is hope at the end of the tunnel, which I think everyone is really understanding that this is required, because each one of us, if we get into an emergency, these are the people who are going to come and help us. So this is the last day when I was meeting health secretaries. I told sir, because sir had come with an emergency, I told sir that we found it difficult to get him from there, because unless we have this agnostic to anyone, like even if it is a VIP or a non-VIP, and we do create such kind of systems which will do en route care, we are not safe. None of us are safe. So, but then I think, sir, your question, I think there is ambulances which are well equipped coming. Now, control over them, I think we need to work on having more systematic way of, trying to have. That's what I told. Leadership governance is one part of emergency care.
I have shifted many doctors from here, from Pondicherry, like to Chennai. So that's why I raised this question, because I have to depend on the corporate ambulances rather than our ambulances.
Yes, you're right.
Please try to do something for the people of Pondicherry, sir.
I think we are all same team, sir. I think we are all working towards the same goal.
Thank you very much, sir. It was wonderful talk, sir. Very informative, right, to all of us, sir. Thank you very much, sir.
Thank you so much.
Right, sir. So we will move on to next topic, that is secondary prevention of stroke. Dr. Vivekanandan Pillai, sir, is a professor and head of the Department of Medicine. He is domain expertise, general medicine and infectious diseases, and he has 40 articles, publications, and his major grants is a recovery trial of COVID through ICMR, which is running now, and intravenous treatment of scrub types. He is a site co-investigator, and he has many publications. I'm surprised because it's going on pages. So please take on them.
Good afternoon to all, especially IMA for organizing this, and Dr. Sunil Narayanan for taking it forward, and our medical superintendent, who has, despite his so many meetings on regular days, he managed to sit through the entire day. I thought he'll be there for inauguration, but it's very challenging because every day he has to sit in several meetings. So I'm very thankful for him for staying throughout. And moving on to, I'll try to minimize. I have a lot of slides, but I will not cover many of them. I'll just limit to what is essential. I have only 2 messages to convey. Point number 1, patients with stroke need high intensity statin. I see time and again the statin dose coming 10 mg, 20 mg of atorvastatin after a few months, even including many times I have seen not in Pondicherry. I have seen in general neurologists managing reducing the statin dose to 20 mg. So this is one. So everybody needs something like atorvastatin 80 or rosuvastatin 40. At least 20 to 40 of rosuvastatin, atorva at least 40, if not 80. So this is number 1. A major error, not error. I would not say it as error. Practice and the knowledge gap is there. So we have to correct that. 1. Number 2, so many patients are on dual antiplatelet therapy when it is not indicated. So unnecessary dual antiplatelet therapy. Second, inadequate statin therapy. These are the 2 major issues I have seen. So that is the main message. Depending on time, I'll cover maybe 5 to 10 minutes. Only 2 messages. Avoid unnecessary dual antiplatelet therapy, DAPT, and ensure high intensity statin therapy. These are the 2 major take home points. If you have a stroke, the risk of recurrence is high. Annual incident may be around 9% risk of recurrence. It can be reduced to 5% by various measures. They found these 5 are the most important: control of BP, dietary modification, physical inactivity correction, smoking cessation, and the obesity, particularly abdominal. If you address these 5, remember, strict diabetic control is not there. It is less important. More important is smoking, obesity, physical inactivity, diabetes, and BP, particularly important. Between BP and blood sugar and blood pressure and blood sugar control, BP control has far greater dividends in stroke prevention, recurrence prevention. Because once there is a macrovascular disease, when we say macrovascular, it is cerebral, coronary, and peripheral. Macrovascular disease recurrence is not much influenced by the tightness of diabetic control. You need to control, may not be very, very tight. So more focus on the other factors. Extreme focus on diabetes is not needed. Maybe they are frail, they are maybe disability. So reasonable control is as good as intensive control. But these factors are important. That is the other point. So give a lot of emphasis for physical activity, weight loss, obesity, and BP control. So these are very important. And if you look at the population level, if you look at these 5, 90% of stroke is preventable. We should not require Dr. Sunil Narayanan's services, ideally. 90% of the time, we should not involve him. That should be our goal, if we are doing our job properly. I mean, as a community, Sitanshu is there. He is the most important person. You are the most important person. After you, we all come. When Sitanshu fails, we all come into the picture. So entirely, it's Dr. Sitanshu's failure that we have to work. He is our community medicine expert. If his vision and his thoughts are fulfilled, then people need not. We don't need doctors, or at least stroke doctors. So that's what we should move on to. So a bit about statin. You have to remember, high intensity means we mean atorva 40 to 80, rosuva 20 to 40. This is the dose we need for anyone with what is called ASCVD. Let me introduce this term, ASCVD. Atherosclerotic cardiovascular disease. Not very clear to people. This means any vascular disease, stroke, MI, atherosclerotic complication, peripheral vascular disease, any vascular occlusion. Or if you did an angio, you found a 50% or more block, even if you are asymptomatic. So if you have angina, if you have TIA, if you have stroke, MI, or incidentally detected asymptomatic occlusion of more than 50% in any of the vessels, cerebral, coronary, periphery, you have what is called clinically manifest ASCVD. So once you have ASCVD, you need intensive statin therapy. There is no question of 10 mg, 20 mg atorvastatin. We need 40 to 80. They're not tolerating, you can combine with ezetimibe. So this is the single most important. We see any number of MI patients post CABG on Atorva 10 mg. Very commonly I see CABG 6 months ago, now on atorvastatin 10 mg. So another 10 years, you will need another CABG at this rate. So the single most important message is statin has to be intensive dose for anyone with ASCVD, which includes stroke, MA, angina, whatever peripheral vascular disease, claudication. Anyone with a vascular disease. We must familiar with the term ASCVD, atherosclerotic cardiovascular disease. So ASCVD risk prediction, ASCVD management is the core of. Stroke is one aspect of it. The same applies to all of them. High intensity statin. We should never prescribe anything less than 40 mg of atorva or less than 20 mg of rosuvastatin. So this is single most important message. Lifelong. Lifelong. We don't have to lower the intensity later. No, it is for prevention of the second event, not for the acute event. All this lipid lowering has nothing to do with the stroke or MI. It's not going to have an effect on the acute stroke. It is only prevention. So prevention is always for the future. So we don't want a second, because once you have an event, you are high risk for recurrence. So this is primary prevention. That is totally different story. Primary prevention is you don't have any of this already. That is different. This is secondary prevention. You have ASCVD already. Stroke, MITA, something has happened. Then you are at a different category. You need aggressive lipid lowering therapy. There is a linear correlation between however you lower, better. The target LDL is less than 70. It could be even less than 55 for those with recurrent MI. So as low. And there is no particular target. If somebody's LDL is 100, you still give high intensity. You don't think it's only 100, I'll give 10 mg. No, it is nothing to do with the patient's cholesterol level. Irrespective of the cholesterol level, give high intensity. With that cholesterol, he has had a stroke. So even with that cholesterol, he had MI. So we have to reduce by high intensity, and the whatever levels LDL he has got reduced by 50%, which needs high intensity. So whatever level he has had an event. So for him, further reduction is needed. There is no lower limit below which it is not useful. You lower to 70, better. Lower below 55, better. There is no lower limit below which it is harmful. So there is no question of unduly lowering LDL. That concept is not there. Unduly lowering BP is there. Unduly lowering glucose is there. Too much reduction could be harmful. Too much cholesterol lowering, there is no concept. So there, no one can reduce the cholesterol too much. There is a mild increase in new on statin therapy. But despite that, there is a reduction in the vascular events and mortality with statin therapy. Even though there is a mild increase in incidence of new diabetes, despite that, the overall mortality comes down, the incidence of stroke MA comes down. So even if that information is there, we still have to give high intensity. So that is the main message. Moving on to this, if somebody can't tolerate statin, we have other options. Ezetimibe is good, reduces by 10 to 20%. Bempedoic acid, new entrant, 20 to 25%. So these two can be tried if they are statin intolerant. Ezetimibe is a very good drug. Outcome trials are there. Bempedoic acid has been shown in trials to reduce stroke, MI, vascular events. They are all outcome proven, not merely lowering cholesterol. They reduce vascular events trials, so they are proven. Bempedoic acid has some drug interactions and side effects like gout, hyperuricemia. So you have to look into that and prescribe. The target is less than 70. So there's a key message for the day. I'm not going to trials. Next is antiplatelet therapy. All patients with stroke require a single antiplatelet therapy only. All patients with the MI also need a single antiplatelet therapy. MI, I'll come to that later. That's not true. For stroke, single antiplatelet therapy. For MI, dual antiplatelet therapy is needed for 1 year after acute coronary syndrome. If you have an MI or acute coronary syndrome, STEMI and STEMI unstable angina, for 1 year dual antiplatelet therapy, then change to single antiplatelet therapy. We see people lifelong dual antiplatelet therapy. It increases the risk of ICH. You can fall, injure himself, you will unnecessary bleeding. So there is no benefit and there is harm. So beyond 1 year of acute coronary syndrome, no need. If you had a stent for a coronary event, the duration of DAPT, minimum 1 year, perhaps up to 2.5 years, there is a benefit. Even with the stent, no benefit beyond 2.5 years. Whether you need DAPT after stent can be as short as 3 months to up to 2.5 years, depending on the bleeding risk. Generally, we continue to 1.5 years to 2.5 years, fine if the bleeding risk is not there. But no point beyond 2.5 years. Minimum, probably roughly around 1 year. Up to 2.5 may be benefit. Beyond 2.5, there is not much, no benefit. So, many people are lifelong dual antiplatelet therapy unnecessarily. One CME per year they take. But stroke, there is no role even for this much duration of dual antiplatelet therapy. There are 2 indications. Some patient need 30 days dual antiplatelet therapy. Some patient need 90 days dual antiplatelet therapy. So you have to decide when somebody comes with acute stroke, many will need single antiplatelet therapy. A small group will need dual DAPT for either 30 days or 90 days. So who are these patients? If you already had a major stroke, there is no role for dual antiplatelet therapy. If you have a stroke or a minor stroke or a TAA, in the territory, you may have a major stroke later. It's a warning. So a TAA or a minor stroke could be a warning for a major stroke which is going to come. So if you have a minor stroke or a TAA, then you need dual antiplatelet therapy. For a major stroke, single antiplatelet therapy. It appears paradoxical because major means the damage is already done. Dual antiplatelet therapy won't help. For minor stroke or a TAA, DAPT for either 30 days or 90 days. Who needs 90 days? This is ischemic stroke I am talking, and I am excluding cardioembolic. RHT embolic stroke we are not covering. When there is a cardioembolic stroke, that is a different, that is anticoagulation. This is for a atherosclerotic. The ischemic stroke can be due to cardioembolism, which is totally different. The case anticoagulation, either MI, intramural thrombus embolization, or most commonly RHT, AF. That is anticoagulation. We are talking about atherosclerotic stroke. DAPT is needed for 30 days. Generally, 90 days if the CT shows intracranial large vessel occlusion, like MCA stem occlusion or a M1 first branch occlusion, stem occlusion will need the dual antiplatelet therapy. That is for 90 days. If it is extracranial occlusion or a small vessel disease, lacunar infarction, 30 days is enough. If you don't know, at least give 90 days. Okay, minor stroke only. Minor stroke TIA, give up to 90 days. If you are not even further dividing into that, okay, 30 to 90 days is fine. I'll show some graph for you to understand. This is the dual therapy. Long-term therapy is not useful. Long-term dual therapy, no difference in the outcome between either single clopidogrel or dual therapy. So don't give dual therapy long-term. But the hemorrhage risk is increased. Dual therapy has more bleeding risk. So by giving dual therapy long-term, you have more risk of hemorrhage, less risk of, no benefit. So don't give. That's what I said. And life-threatening bleeding is 3% versus 1%. So it is actually harmful. Sorry. How do I go back? This one here. So trials have shown no benefit, maybe increased hemorrhage. So dual antiplatelet is not there long-term, maximum 90 days. So if you have a TA minotrect, what dual antiplatelet, you give aspirin, loading 300, because we need immediate action. Minor stroke, major stroke to be prevented. Give loading dose of aspirin, clopid, and give a maintenance dose. This is for either 90 days or for 3 months, depending on where is the site of occlusion. This is what a major, if occlusion is the intracranial, M1, A1, any of the intracranial stenosis will need a 90 days. Otherwise, it is 30 days. That's all. If you are not sure, leave it 90 days max, not beyond. I am not going to that. This is to show that even if the 90-day dual antiplatelet therapy, if you look at it, the benefit is there in the first 30 days. The graph is not different. The difference is achieved in the first 30 days or so. So continuing beyond that, continues the risk of hemorrhage, benefit is not there generally. So generally 30 days is enough. That is the only message. I'm not going to any of the details, not needed. Ticagrelor also has been used. Now we're coming to BP control, which was a discussion. Let us look at 3 things. One is ischemic stroke. Second is hemorrhagic stroke. So to take totally different recommendations. So if you have a hemorrhagic stroke, sir, how many minutes I have? If you tell, I'll adjust accordingly. I can adjust accordingly. So if you have a hemorrhagic stroke, first question, what is the systolic BP? If it is between 150 and 220, in hemorrhagic stroke, the hematoma expansion has to be prevented. So you have to control the BP. Ischemic stroke, don't reduce the BP. Hemorrhagic stroke, reduce the BP aggressively. Different approaches. Hemorrhagic stroke, but when you see the patient without CT, you don't know. So at that point, you can't take a decision. This is only after you have seen the CT. So 150 to 220, you reduce the BP to 140 within 1 hour. That is the recommendation. You can reduce rapidly to 140 within 1 hour. Ideal drug is either labetalol IV or IV esmolol or nicardipine if available. I haven't used nicardipine, so I'll limit my comments to nifedipine. Labetalol or esmolol. Sublingual nifedipine is contraindicated. It's unpredictable lowering, so we don't use it. That's fine. If in a hemorrhagic stroke, the systolic BP is above 220, then they are hesitating because the BP is so high, there the rapid lowering could, the perfusion could be affected. So there some pressure is still needed to push. So then don't lower too much. The systolic BP is above 220, you immediately reduce to below 220 first step. Say from 240, 230, bring to 210. Then you reduce over several hours, somewhere around 140 to 160. Over several hours, over the 24 hours, several hours. More gradual reduction to a more moderate 140 to 160. Whereas if it is within 220, bring it down straight to 140 within 1 hour. This is the recommendation. How to implement practically, what drug, how to adjust, what risk. That's we don't have enough time to discuss. Just let's see. This is what we have to do. This is for the hemorrhagic stroke. Systolic 150 to 220, bring within 1 hour to 140. Above 220, reduce below 220 immediately. Then from there, over several hours, bring to 140, 160. So we are done with hemorrhagic stroke. Go to ischemic stroke. If you are going to thrombolize, bring immediately below 180, 185, 110. Below 185, 110. If you are going to center having thrombolysis will be able to bring it down quickly. They'll have the expertise of labetalol. So we leave that. That is that. That center will take care how to reduce. Will not go into that. If the patient is not eligible for thrombolysis beyond 4 hours or 6 hours window, no access to mechanical thrombectomy, it's not there. What we can do is the question. Now, without thrombolysis, the higher pressure is needed, already vessel occlusion. So the perfusion needs a little bit of higher pressure. If you are thrombolizing, you are removing the block. So you can reduce the pressure, remove the block. But if the obstruction is there, then lowering can be harmful. So do not lower BP significantly in the first 24 hours is the message. So up to 120, don't reduce. Don't reduce blood pressure in the first 24 to 48 hours. If the blood pressure is 220, 120 or less, the first 24 hours or so, the ischemic brain depends on high pressure for the partially viable neurons need the high pressure for maintaining what is called cerebral perfusion pressure, CPP, which depends on MAP minus ICP. ICP is high because of the infarct swelling. ICP goes up, you need higher MAP to perfusion. So that's why first 24 hours this happens, 24 to 48 hours. After that, you can reduce. If it is more than 220, 120, you reduce by 15% over 24 hours. Some reduction over 24 hours. So that is the idea. So if it is more than 220, 120, by 15% over 24 hours. If it within 220, 120, don't reduce in the first 24 hours or so. By 24 to 48 hours, the clinical, whatever deficit would have happened, happens stabilize. Then you start lowering. Then you can bring to somewhere around 148. Usual target BP comes, which is usually below 149 over the several days in the hospital. There is a subgroup which a large intracranial occlusion. You may have to delay the blood pressure lowering for 1 to 2 weeks. We may keep it at a slightly higher level. So that is the point about something garbled. We leave it. In the long term, the target is you keep it less than 130/80. Long-term BP. This is one secondary prevention. True secondary prevention I'm talking. The target is less than 130/80. General target is 140/90 for most people. Below 140/90. For otherwise healthy individuals, we advise below 140/90. About 10 points less for the anyone with a already having stroke, MI, CKD. That group is a greater benefit from intensive lowering. So the target is 10 millimeter less. This is the office BP. If you are doing a home BP, the target is plus. It is 120, instead of 130/80, it will be like 125/75. You can, home monitoring may be better. This is one study. Interestingly, this is the people with the office BP. I think time won't be there, but you can see that this is the measured BP in the office. After so many people, even with the 240, 220, 200, half of them had a home BP which is less than 130. So you had an office BP of 240, home BP of 120. Office BP of 230. In the West, I think they hardly bother too much about doctors. They hardly have so much fear or respect for doctors. Even there is white coat. Here, we don't have to say. It's very common. So home BP, see, office BP of 230, 220, like that, 200. Even they have a home BP of 120. So this whole is white coat. Here office BP is high, the true BP is also high. This is the usual hypertension. Here office BP is below 130, but home BP can be higher. So that is called masked hypertension. You may have an office BP which is normal, but they may be having hypertension at home. And you may have an office BP which is high, home BP can be relatively normal. So ideally is to have a home BP monitoring and go by that if possible. Otherwise, you have to make the patient rest for 5 minutes, then measure after rest and all, you may get a true blood pressure. Okay, so that is 6 millimeter. If you reduce, you can reduce the risk of stroke by 20%. It's a powerful reduction in the stroke recurrence by even small millimeter, 5 to 6 millimeter reduction. So that is the key. So this I'm not going into that. Diet, I will not go into that. Physical activity, even 10 minutes 4 times, 40 minutes is even okay. Even 10 minutes 4 times is okay. 40 minutes. Ideal is 150 minutes, 30 minutes for 5 times a week, 5 into 30, 150. Even 10 minutes 4 times has some benefit. So at least this much has to be done. There is a newer drug, colchicine, as shown in trials to be effective in preventing stroke recurrence, but I think still at the trial level and not at practice level. So summary, long term only single antiplatelet therapy. DAPT maybe 30 to 90 days in only those with a minor stroke or a TIA. Once you have a major stroke, there is no role for DAPT. All patients should receive maximally tolerated statin with a goal LDL of less than 70. BP target is less than 130. HbA1c try to give less than 7, but the benefits in stroke reduction is much less compared to other measures. So if it's difficult to achieve, maybe you should focus more on other measures. Of course, diet, physical activity, extremely important, but I am talking later because not that it is less important, it's more important, needs more effort, needs more discussion. So we all need to work on that. So
thank you very much.
So
one question, sir.
Yes.
So whatever you said about hemorrhagic stroke or ischemic stroke,
yes.
just bring down the BP to this level, 220, ischemic stroke, 120, 180. All you're saying, all these things are applicable only at the tertiary level.
At least secondary level.
At least, okay, secondary level. At primary level, I don't think anyone has that confidence. Even they were discussing with me, right? They don't have any confidence.
I don't have
the
confidence.
BP is about...
I won't have confidence also. It's acceptable. See, first of all, if what I'm saying, even if you give labetalol, you have to monitor and adjust the dose every 10 minutes. So you have to retain the patient for 10 minutes, recheck. It's not possible.
Yeah, so, exactly. So
it is all right. It is all right. Maybe you give a 10 mg of labetalol IV and send if it is 220 above 10 mg IV and send the patient.
Thank you very much.
That should not lower it too drastically.
So this hemorrhagic, ischemic is all possible
after CT.
After CT.
Yeah, before that we don't
know. Before that we don't know. So
we don't
know.
From
above
220 center refer ASAP. That's how it is, right?
Above 220, anyhow you can lower, irrespective of whatever the underlying cause. Above 220, 10 mg of labetalol may be given. Should be okay. Should not lower it too much.
Because we are not going to give aspirin or
we can't
give before we ship.
So that's why more of our knowledge is where to send the patient, how to send the patient is more important. Triaging is the main role, not treatment. Guiding is more important.
Can't aspirin be given before shifting?
No, sir.
Without CT, we can't.
Without CT.
Unless we have
without CT, we can't
that
give.
small portable scanner comes, no, sir. It is not.
Actually, the current recommendation is that if you don't have any immediate CT available, there is no significant damage by giving that aspirin dose, even in patient has had hemorrhage. That is the current recommendation. So you can give aspirin if there is a stroke and the CT is going to take time. Not too much of worsening of the hemorrhage will happen even that single tablet of aspirin.
So,
Sir, also, sir, even
So
in
if
ischemic
you-
stroke, if I may say so, even ischemic stroke, if you start aspirin within 12 to 24 hours, it's okay. So a delay of few hours, even in ischemic stroke, is not going to make an outcome difference. Suppose you have seen the stroke, it will take another 3 hours for the CT, and then you will give aspirin. It's not going to have a major difference even in ischemic stroke. Delaying the aspirin by a few hours is not going to alter the outcome. If you start within 12 to 24 hours, should be fine. So either way, options are there.
If it's a TIA or minor stroke, then it's very important to give it as early as possible because we may not be giving thrombolysis also. And they're asking about the dosage actually. So the recommendation is actually if it's a TIA, give 325 milligram of loading dose of aspirin. Plus, in fact, now
600
the consensus is that plus you can give also 75 milligram as a loading dose of this combination in a TIA or minor stroke. If it's not hemorrhage, this combination. If you have already given IV TPA, only after 24 hours, you start the aspirin.
Yeah. So one last question on diet. Instead of 100%, there is sodium chloride. The combination of 75% plus 25% of potassium chloride.
Yeah.
Do you know any studies on that?
This replacing part of the sodium with potassium chloride has been shown to reduce vascular events, I think around 15%. It's a good option. Only problem will be people taking ACE, ARB inhibitors, aldosterone inhibitors, CKD have to be avoiding that. It's a good option.
Okay, so what about vitamin C, D, and E supplementation, sir? Long term.
I am not aware of any benefit from C or E. D, I have not looked at it. If the deficiency, perhaps you need to treat in general, but I'm not aware of any specific data, sir. Deficiency can be correct.
No, thank you very much, sir. So we
non-hemorrhage. Okay, acute stroke. Okay, sir. Violent patients, sir. Alcohol withdrawal causes marked restlessness. Also, the alcohol withdrawal leads to severe restlessness. One of the most difficult things to control the patient. You need 2-3 people to hold. So the best is to give lorazepam, IM. IV may be dangerous in a not so advanced setup. So I would give 2 mg to 4 mg of IM lorazepam. Haloperidol can be given. Serenase, about 5 mg IV can be given.
Quetiapine is also another.
That will calm down him in about 20-30 minutes. Definitely to calm. So oral, if you can manage to give, lorazepam should work, but it will take some time. It will take an hour. But if you don't have access to IM, then maybe you can give oral. 4 mg of lorazepam can be given. Repeated maybe within 2 hours also you can repeat one more 4 mg. He will calm down sufficiently in about 3-4 hours time. You need 2-3 people holding on to him. So now the most difficult things to hold on to a alcohol withdrawal person.
Thank you very much, sir.
You will get some strength training also in the process, I think. Even though we have a sedentary life, if we handle some alcohol withdrawal, probably will develop some high intensity training. High intensity intermittent training could happen. Yeah?
Thank you very much, sir. Sir, just please wait, sir. Now I call upon for the panel discussion, Dr. Professor Sitanshu Kar, then Dr. Batma Priya, because Professor Naveen Kumar is not available here, then Dr. Savita Shekhar and Mr. Devam. Yeah. Please come on to the stage here, everybody. May I request our medical superintendent to honor all the...
Devam is here, huh?
To all the speakers.
Some of the questions we have to refer to Devam only. Finally, you don't have any answer, we'll ask Devam. That has to be done. I didn't see it. It's not there. Usually difficult to get Devam. You can't get it.
So just before the panel discussion.
That's Sunil, Devam is not there, huh?
Yeah.
Difficult to get as it comes. Deva means God. So
Just before the panel discussion, we have a
no, called Deva means God.
small formality of honoring our guest of honor and also the other dignitaries with a small memento. So kindly give a small break.
You can make it. The photo is taken. Put it. We have not done anything.
So it's not over. There's going to be before I know you, so we are standing between you and lunch. But there are three more very interesting with short useful information. Starting with a brief on primary prevention, because we want to prevent strokes rather than actually having strokes and then starting to treat and rehabilitate. So, yeah, Professor Siddhanshu is an expert committee member for the prevention of NCD in various groups in India and also in our state and in the regional forums. And he has been very active in this area, very passionate in this area. We are in the NCD programs also quite some time. But Dr. Siddhanshu, please.
So can I have just 2 slides to show? Is it okay to? Good afternoon. So initially I thought that there will be some 5 to 7 minutes available. Now it is 2 minutes. So 2 slides. So I have been asked to talk about the primary prevention, but before that we need to understand what is primary prevention. So primary prevention and primordial preventions are 2 things that we should always remember. One is primordial prevention is prohibiting the emergence of risk factor, and primary prevention is health promotion and specific protection. So when we are trying to look at stroke, what are the factors that we should prevent to go into that condition before this emergence of risk factor is primordial and primary. So, So who are the people whom we should target in primary prevention? The primary prevention target should be whole population and at-risk population. So the whole population, when we are trying to tell, we are not talking about pharmacological, we'll talk about non-pharmacological management more here. And the issue is government, legislative measures, fiscal measures are also a very important part, which the health department has to advocate for the from the policymakers to do. This draft you have seen, this is a very important book for the guidelines for prevention and management of stroke. The risk factors mentioned in this book, how do we do is, one is non-modifiable, we cannot do anything about it. The second one is modifiable. The modifiable risk factors are high blood pressure, diabetes, all those things were told to you. I'm not going to repeat it, but what should we do about that for the population level? So managing stroke at primary care level, as per this book, the recommendation from the ministry, it talks about primary prevention has got two major components. One, population-wide strategy and high-risk strategy. When we talk about population-wide strategy, we have to involve everyone, starting from the early childhood till late adulthood. So this is a graph that is very important. Why? If you look at the dashed graph, the pointer is working. This is the current distribution of systolic blood pressure for example. What we want is, we want the curve to shift towards the left-hand side. If we shift the curve towards left-hand side, the number of events will go down in our community because sick individuals are from sick population. So what we do is, we work here usually high-risk people who are got hypertensive, we try to give drugs to them and control their effect. But we should work in this graph, in this population, which is actually 75% of our population. So that is what we need to understand, and we try to work on that particular angle. Early recognition and referral is also a very important component that is already been highlighted earlier by Dr. Sunil and all other Dr. Vivekanandam, a good friend. So they have told about those conditions, and final thing is rehabilitation. So lifestyle modification, this is the American Heart Association, Life's Essential 8. Please take some time to tell your patients about this. Even if they are not having any symptoms, this is what we have to tell. In this way, we can reduce the general population-wide approach and the risk can be minimized. What are those? So 5 servings of fruits and vegetables, do physical activity for 30 minutes per day, moderate intensity. Then what we should do, no tobacco, no smoking, sleep adequately for 7 hours. And all other things are lipid lowering and your blood pressure control, your blood glucose control, ideal body weight are life's essential 8. We have to remember this, and we have to keep telling to our patients whenever we meet them. Early recognition, we have talked about first, now it has be first. Now there is another term that they have given in Hindi called Bachav. What is Bachav? Bachav, B stands for Baju. Baju is arm. A for Awaz. Awaz is your speech. CH is the face. Then V is Bakt. Bakt is time. The same thing is converted into Hindi wherever they have given in the manual. That's why I told. Otherwise, face drooping, arm weakness, speech difficulty, time to call. And B first. B is our B is balance. E is eyes problem. So I was trying to look at how many of are paying attention. So B first is that particular thing. Anybody who recognizes, we have to teach our students, school students, teachers, so that they can be the ambassador of change in our community. Health promotion starts with creating awareness, but it may not be always very rewarding. But with that, I'll stop. So primary prevention, 2 things to remember. 1, essential 8 of life. Second is early recognition and warning symptoms, so that we can refer the patients immediately, or people will know that, okay, early stroke is coming, they should go somewhere. So that is the overall message from our side. Thank you so much. This is the last slide. Thank you.
So he has answered the most important question. What do we do at the PHC? So PHC plays the major role of primordial prevention, primary prevention, and once stroke is treated, rehabilitation, secondary prevention, and when the patient comes to you with some symptom, is it really stroke? Because many times the stroke is not very clear. Obvious stroke we are talking, but facial palsy, Bell's palsy versus stroke, some he slept on the hand and numbness versus real stroke. So recognizing stroke as actually is a very important role of the primary care. So we shouldn't feel that we are not doing much for stroke. Actually, we are doing much more at the primary care. No, I'm saying, so you are recognizing that as not stroke and not overloading the system with emergency call shifting. So that's a key role of the primary care. What is stroke, what is not stroke? Recognizing and referral is the role, not necessarily treating. Recognizing stroke is a major contribution. That is what we should feel, that we are not doing anything. No, you are doing a lot. We are not acknowledging it. That is the problem.
So regarding insurance schemes, Dr. Savita Shekhar, can you please highlight about it?
Good afternoon, everyone. In JIPMER, we have various government insurance schemes which are operational. As you know, the National Health Scheme, Ayushman Bharat Jan Arogya Yojana. Then we have the Central Government Health Scheme. Thirdly, the Comprehensive Health Scheme by Tamil Nadu, Chief Minister's Comprehensive Health Scheme. And we have Neyveli Lignite Corporation also operational in JIPMER. See, as you know, the design of these health schemes are mainly to target the low-income group families so that they get the appropriate treatment without any financial hardships. So what we do in JIPMER is we meet each and every patient who visit, identify the low-income group families. We find out whether they have already been enrolled. And in case they have not been enrolled, then we emphasize the need for a scheme, because illness is something that we don't expect. And every patient has two aspects, very important aspects. One is emotional part, the other is the financial burden. And if the financial part is managed, the emotional, the family, everybody is around them. So this is what we do. Then we have our outreach centers. Our doctors play a very important role where they do home visits. They identify these low-income group families and they educate them. They, if possible, they generate the card, or if they don't have the required government documents, which is very essential, two important documents. One is the ration card, and second is their income certificate is also very important, and their Aadhaar card. These, if they have these documents, it can be generated in the hospital. If not, they can go to the nearest customer service centers and get their respective scheme card. And no patient can be treated without being a beneficiary at the time of admission. So it is very, very essential that at district level, PHCs, doctors give a little importance to, apart from the treating the patient, to educate them about the need for a insurance card. So this is something that I would like to request at a district level or a PHC anywhere. Then we have dedicated packages for different conditions, and it can range from anywhere from 14,000 to 5 lakh packages available. And in case there's no dedicated package, then we have something where if a patient is in a general ward, the financial care support is given up to 2,300. If a patient is in a high dependency unit, then it goes up to 3,800. If a patient is in an ICU with a ventilator, it can go up to 10,500. Without a ventilator, something around 9,800. So there are options, and we try our maximum at JIPMER to bring every patient who's a beneficiary under the package. If we can't identify, we find ways. So to reduce their financial burden. So this is what we do. And if there are any questions, yes, sir. No card, sir. So we will not deny treatment. Yes, we do generate, sir, because in Ayushman Bharat, we have an option for up to 5 days. A patient can be, we have 5 days time. Yes, within 5 days, we'll have to generate the card. Yes, sir. But but most of our patients are from Tamil Nadu also. 70% of our footfall is from Tamil Nadu. So then they have a clause that a patient has to be a beneficiary at the time of admission. So we have very little chance to bring those patients, but at JIPMER, we don't deny any treatment. We still continue. Then at least for the subsequent follow-ups or visits, then yes, they would be. So Star Health Insurance, we don't handle. It doesn't come under, it is no more under the government schemes. Private, but that's a different unit. Yes, sir. Yes, sir.
Yeah, I think in a government
Dr.
institution, it will have to follow
No,
their own regulations.
Do you have any scheme for taxpayers in
What, sir?
Jipmer? What all you told about is
Government doctors, if they are CGHS doctors.
One person at a time.
CGHS.
Sir, let the others ask question and we will come back to you. Sir, we already answered that question. That is, if you are going to a particular institution, we have to follow the rules of that institution, whether it is private or public, whatever is prevalent in that institution, though they are following their regulatory authorities' guidelines. So we have to stick to that. The moment central government approves the use of Star Alliance in Jipmer, we will also follow it. So until then, we will have to wait. As it is, we will have to follow this.
So what are the insurance do you accept? That at least you can highlight.
We have the government insurance schemes. That is main is Ayushman Bharat.
Ayushman Bharat.
Then we have the CMCHS TN card.
Okay.
Then we have the CGHS.
CGHS. Okay.
For CGHS, we don't have any package. We can treat the patient and whatever the income, I mean, whatever the expenses are incurred, that would be sent to the CGHS office and then they would reimburse the amount.
You can come through CGHS.
I have a question.
Sir?
The acute patient coming in the night, we may not be able to provide, we get a pre-approval for a procedure like mechanical thrombectomy. And, it's a costly equipment and now costly procedure. And there are schemes for things like carotid angioplasty, etc. It's a secondary prevention. But patients who need acute care at any time, 24 hours, the a procedure like mechanical thrombectomy runs into a few lakhs.
Yes, sir.
So we have a small issue of it's still needing the pre-approval. So whereas it's in practice, getting the pre-approval is next to impossible. So what do you recommend it to?
So if the patient is from Tamil Nadu, we have an option to bring a patient under an emergency code where you don't need a card. Then the next day, we ask the patient's attenders to provide us those relevant documents. If they stay far off, we still have 48 hours for them to go and bring the cards. If they have, then we raise the pre-authorization. But for Ayushman Bharat, we still have 5 days left. So we
regarding any scheme, Tamil Nadu government servants, retired pensioners.
So no, sir, they don't come under the scheme, sir, because the income has to be 1,20,000 annual income.
Ah, yeah.
Yes, sir. They no, sir, we don't handle that. Sir. We are limited only to these 5 schemes.
Sir, are we giving tenecteplase
Yes, sir, we do.
free of cost?
Yes,
To all the patients, because you said some scheme is there at the national level. That's why I'm asking.
It's being given free of cost.
Thank you. Next question.
So Ayushman Bharat emergency option, but then we have 5 days time, so we can bring a patient within that
senior
period, sir.
citizens health insurance scheme. Recently, Prime Minister has announced that. Whether it is applicable.
70 years.
No. Senior citizens health insurance scheme.
Yes, sir. It is applicable and we have started it. You don't have to have a card, sir. We can generate it on the day they are admitted, sir.
Given. He said free of cost.
Yeah, tenecteplase is available, sir.
Tenecteplase.
Citizens? Yes, sir. At that minute, we can do it, sir.
The idea is that the way the principal government works is that nobody should be denied of it because of financial shortage. So all BPL patients will get it totally free of cost. Those who can afford, they should be encouraged to pay. So the thing is, everybody is given the injection irrespective of whether they have money or whether the drug is given. Then those who are above BPL or to reimburse it it will come in the bills, but it will be exactly the cost of the drug alone. So this is the general principle, only if those who can afford or those who can get other forms of reimbursement pay, then only it's a sustainable, continuous delivery of free care service to BPL is possible. Absolutely. Absolutely. There is an emergency service. Through that only 24 hours you can come to the specific neurology clinics. We have 4 days. We have different clinics actually. For example, Tuesday we have exclusively stroke clinic. No. Emergency will always come through the emergency medical services. Dr. Manu was giving, and we have through casualty. None of the specialties you directly are applied. Go to the EMS and EMS will call the concerned specialties.
Sir, good afternoon, sir.
And it's done in a very fast pace, so there is no delay happening.
Sir, it's already 2:12. Last question
Sir,
to
sir,
Dr. Padma.
Sir, Dr. Srinivasan, sir, 1 minute. I got doubt. Sir, I am a doctor from Tamil Nadu, retired as a director of medical service. We have given a health insurance for the pensioners. Whether it will be applicable if I get a treatment here? No.
Not applicable. So next question to Dr. Padma Priya. Padma Priya, how do you find, can you highlight something about rehabilitation?
Sir, so Shitanshu sir as well as Vivekanandan sir has already focused on the primordial and primary secondary level of prevention. As a rehab physician, I have to focus more on the tertiary prevention, not only preventing the risk factor. So what are the secondary complications following stroke that has to be pre-identified and rectified? Otherwise, we will lead into the tertiary complications of stroke. The second point I want to focus on more is like social reintegration of the patient back to the society as a fruitful member. How far the patient needs are fulfilled, that we have to assess. It's not like we have done the job, like send the patient to medical social. We need to assess more on that. The second thing, community level, what can we do for a acute, subacute level of stroke patients? That I think we need to focus more on that. So like more like in acute phase, what you'll see is like a shoulder subluxation. Later it leads into impingement syndrome or a periarthritis shoulder. Mostly you'll get to go see a patient with the I'm not able to use my hand, but I'm able to walk. This is how the patient will present on a subacute or chronic phase. So how we are going. Usually you'll see altered gait abnormality. The patient will be mostly on a circumduction gait pattern or a vaulting or hip hiking. So this will leads to again secondary use of myofascial pain syndrome. Periarthritis, another topic which has to be focused was a hemiplegic shoulder. In acute phase, you'll see a complex regional pain syndrome. To the far extent, you'll go for a shoulder adductor internal rotator spasticity. So functional outcome of a affected upper limb, that has to be assessed and given according to the treatment. So initial phase and acute phase, when up to what period you have to keep in the patient in the bed, because you can't keep the patient for 6 to 9 months or 1 year. So how long you want to admit the patient with once the patient medically stable? So even with the grade 0, the patient can sit with the application of compensatory strategies. I think the patient, once you teach at least a bed mobility and self-care areas, if it is taught, the other members can go for work irrespective of staying with the patient. So that's where other sub-departments and paramedical specialties comes in around.
What is your role on like established stroke, bedridden? They are in the house, right? So many people I have seen. So what do you think about it? I mean, from your point of view.
The completely bedridden patient, if he is grade 0, established stroke.
0.
The basic home-based exercise, just a range of motion exercise itself prevent many complications. Range of motion exercise means just moving the joints around. That leads to sensory input towards your brain, one thing. The second one, it can prevent the DVT or orthostatic hypertension. Even pressure sore can be prevented with the range of motion, like 2-hourly position change. These are very, very basic, simple, that can be taught to caregiver. Apart from that, the splints are available, orthotic instruments that can prevent the TA contracture or finger flexure contracture if you apply it in the subacute phase or acute phase. Even while sleeping, if you ask the patient to keep the shoulder in abducted and external rotated position, you can avoid the periarthritis or shoulder impingement or rotator cuff injury, anything. If the patient is on standing phase, just ask the patient to stand for 30 minutes in a day. That causes just ask the patient to stand by holding the window like that, by putting some like bed sheets around the hip region. Just stabilize the knee alone. That will prevent the orthostatic hypertension as well as wasting of muscles. And it gives a psychological aspect of well-being also. Apart from that, rehab physician to assess other things. The basic thing is that range of motion exercise, 2-hourly position change, and standing, assisted standing with some help of a caregiver or just with the help of a bedsheet around the hip regions, them to stand for a minute. That itself prevent other complications like iguanus contracture, everything.
So one issue which I found in many patients, we discharge, and I said there are people coming back after 6 months and 9 months walking. So that's great satisfaction. But there are also patients who after discharge back home, the bad strokes, they are hemiplegic, they continue to have various pains and rehabilitation related issues. And also there are some problems in, continue to have some problems in swallowing or in urination, defecation, etc. And their care, what do you think, what is the best model to take care of them at home? Because many people say they have to work or they have to look after children, and they can't afford to keep a full-time person to take care of these patients. In Western countries, developed countries, there are old age homes where they are completely looked after by the state. In many Western countries, we are nowhere anywhere near that. We have old age homes. Most of them are daycare centers. People can go read the newspaper. There are people who are walking, talking patients. But those who really need this kind of care back home with hardly anybody to support, they can't buy a alpha bed to prevent bed sores and all. So we are losing such patients also.
Sir,
so any schemes or plans are in the development for community care of the discharged patients?
Regarding schemes, I am totally unaware of. But the thing is that if even the patient is completely grade 0, he can ambulate with the help of an assistive device.
There are actually community schemes available, sir. We in our UHC and RHC, there are NGOs who are working and coming and giving them various appliances for their work. And but this bed and other things, they are not. So we have not reached there. Bed, but air bed, water, Alenco, yes. Dr.
I think Sunil can.
Sunil is our
insight into that.
in charge of RHC.
Yeah, there is Alimco, Government of India undertaking.
Sir, since you asked about studies, I want to just share information. Indian Council of Medical Research, through its Instruct network, conducted a nationwide multi-centric trial of early discharge and assisted home care. And what they found was that it was actually a negative study. It did not show superiority of repeated hospital visits care compared to that. We were hoping that with good home care available in India, because of our our societies, our cultural aspects, they will be the people will be getting good care at home also. So assisted supervised home care will be better. That was the hypothesis. But unfortunately, that is a negative study. It was not actually any superior to the currently ongoing unsupervised and hospital and institution-based intermittent care actually.
Under the Department of Social Justice, there is some financial schemes available. They're given some financial assistance. Maybe Dr. Sunil, would you like to add a little more? It's already there, sir. It's already there.
We have problems of the insurance not being available to the for rehabilitation also. That also adds to the misery of people. None of the insurance schemes care for the payment and costs involved in institutional rehabilitation or repeated visit to an institution which provides excellent care. Corporate hospitals are all giving, but the insurance schemes are not helping them. Something which Ministry of Justice is working on. And one last point, there are excellent community rehabilitation centers available in developed countries for a certain region, some center, and even cities and bigger. But this is also something which we have to develop. Our country has to develop because they are developing infrastructure in everything else. Health infrastructure includes community rehabilitation also. That is something which the government has to work on. We are in fact talking to DGHS about the importance of this.
Regarding this support from the government, I think there is a scheme existing in Pondicherry government. Patients who require prolonged treatment, they will be provided subsistence allowance around from 2,000 per month or 500 to 600 per month.
That financial assistance, sir, benchmark disability is there 40% for eligibility criteria. So 40 to 60% around 1,000, 60 to 80,500, more than 80% they will be given a monthly allowance of 2,000 rupees. Apart from that, AADP, as said, orthotic appliances will be issued under the schemes, but not about the alpha bed and all. I'm not sure about that. Orthotic appliances are there. Apart from that, many have an awareness of issuing disability certification, but the reservation also for employment, they have a occasional. For group B and C poster, they have a 4% reservation. For education, they have a 5% reservation. So while discharging the patient, we can give awareness regarding this reservation also.
It also travels. They have half the railway rates for one person plus caretaker if their disability is more than 40%.
40%, the benchmark disability. Only if they are more than 40, they'll be eligible for all the schemes, nationwide schemes.
Thank you very much, panelists, Dr. Padmapriya, Professor Sitanshu Kaur, and Dr. Savita Shekhar. So we next IME CME meeting is Sringeri Sharda Equitas Hospital. Updates in oncology going to be conducted at Hotel Hananda on 23rd of this month, February. Okay. So now I request our Dr. Sunil Yadav, Chief Medical Officer, JRHC, Ramanathapuram Jipmer, and as well as he is our IMA Joint Secretary, to give word of thanks. I profusely thank Dr. Narayan sir for organizing this program. All credit goes to Dr. Sunil Narayan. Thank you very much, and Dr. Vivekanandan sir for his excellent presentation.
And Dr. Sunil Yadav has also taken a initiative.
Sunil Yadav,
coordinate. Thank you so much, sir. I wanted to correct in a lot of communication. It is coming Sunil Yadav, but I'm Sunil Jadhav. But I didn't reveal. I wanted to tell in this platform. So Sunil Jadhav. Okay. Respected dignitaries, esteemed guests, and dear colleagues, it's indeed an honor and privilege to deliver vote of thanks of this CME. First and foremost, I express my deepest gratitude to our chief guest, Dr. V.S. Negi, Director of JIPMER, for gracing this occasion and for his inspiring words through online mode. A special thanks to our guest of honor, Dr. L.N. Dorerajan sir, Medical Student of JIPMER, for his valuable presence and continuous encouragement towards academic collaborations. Our sincere appreciation goes to Dr. Sunil K. Narayan sir, Professor and Head of Neurology, and Dr. M. Vivekanandan Pillai, Professor and Head of Department of Medicine, for delivering an insightful and enriching sessions. I also extend my gratitude to Dr. Sitanshu Kaur sir, Professor of PSM, and Dr. Manu Ayyan, Associate Professor of Department of Emergency Medicine through online mode, and Dr. Padma Priyadarshini, Assistant Professor of PMR, Dr. Savita Shekhar, Senior Medical Officer of Insurance Wing of JIPMER, for engaging and thought-provoking scientific sessions that has added immense value to the CME. Heartfelt thank to IMA Puducherry, led by Dr. Sudhakar, Dr. K. Sudhakar and Dr. G. Srinivasan, for taking initiative to collaborate with JIPMER for this wonderful academic event. Such partnerships strengthen our medical community and pave the way for continued learning. Finally, I thank all the faculty members and participants who have contributed to making this CME a grand success. Your enthusiasm and engagement have made this event truly meaningful. I also thank our IT team, Ms. Kavita Madam and Dr. Chitoria Sir, who has made it possible through online made. Thank you, one and all.
Thank you, Kavita Madam.
I request you to join for a lunch. Thank you.
We thank the IT team, Kavita.
Thank all of your participation. I think that is the most important thing. All of you have come and joined, and that eagerness to continue our learning process to help patients to deliver better care, always appreciated. Yeah.